Good morning and welcome to the January 29th meeting of the Joint Standing Committee on Health and Human Services. We are present here today behind the horseshoe for two public hearings this morning, which we will hear in this order: LD 2065 followed by LD 1996. We have a presentation and some work sessions scheduled for later this afternoon, so a full day. We'll start with some committee introductions, and I'll start with Representative Graham down at the end.
Thank you, Madam Chair. Good morning, everyone. I'm Representative Andy Graham. I serve the people of North Yarmouth and the majority of Gray, House District 105. And it's a beautiful day, particularly driving up in the snow and the beautiful blue sky. So thanks.
Good morning. Welcome. I'm Representative Lucian Daigle. I represent House District 1, the northernmost part of Maine. And I don't have any competition for the most beautiful spot in Maine, so we are it today.
Hello, good morning. My name is Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Hi, I'm Michael Lemlin. I represent House District 53, which is Chelsea, Randolph, Pittston, and Dresden.
Good morning, everybody. I'm Representative Dan Shigori. I represent House District 55, the communities of Holwell, Manchester, and West Gardner.
Good morning. My name is Julie McCabe. I represent District 93, part of Lewiston.
Representative Griffin is on Zoom. Would you like to introduce yourself?
Yes, thank you. Good morning, everyone. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levant, and Kedeskig.
Good morning, everyone. I'm Senator Henry Ingwerson. I represent Senate District 32, the best Senate district in the state. It's the city of Biddeford and the towns of Arundel, Dayton, Hollis, and Lyman. And I bet the weather down there is great. And I'm pleased to be the Senate chair of this committee.
It's a mouthful. And I am Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, parts of Kittery and South Berwick. We are also joined today by our nonpartisan staff, Sam Seneft from the Office of Policy and Legal Analysis, and our very capable clerk, Sophie Dubé. The committee will hear testimony from people present in the room and on Zoom who wish to speak for, against, and neither for nor against the bills being heard today. With leave of the chair, committee members may ask clarifying questions of the person testifying today. The public hearing is just that. It's for the public. The committee will have the time for deliberation and debate at the work session that will be scheduled on these bills in the next few weeks. We'll take testimony from folks in the room in the following order: those in support of the bill, those opposed, those neither for nor against, but with additional information for the committee. This committee will give members of the public priority when taking testimony. Only the bill sponsor and co-sponsors will be recognized before the public. We do run a 3-minute clock here. You'll see the clock on the front of the horseshoe. As you're approaching the 3-minute point, please wrap your testimony up. We do not run the clock for legislators and out of respect for members of the department who provide testimony to us. If you have prepared testimony, please provide 20 copies if you have them to our clerk. You can leave them at the end of the horseshoe next to Representative Lemelin. Whether you testify or not, you can submit written testimony to the committee. Please be mindful that testimony is public and available to all once presented. This hearing is live streamed on the legislature's site as well as YouTube, and there is a recording of the meetings. Please silence your electronic devices. And if you have any technical difficulties, you can call 207-287-1317. Some of our committee members serve on other committees, so you'll see us coming and going to other committee rooms and also to introduce bills. You'll also see members of the committee eating and drinking behind the horseshoe. You're welcome to drink water here in the committee room, but we ask that you don't eat. With that, we will open the public hearing on LD 2065, sponsored by our own Senator Ingerson.
Good morning, Representative Meyer and fellow colleagues on the Committee on Health and Human Services. As you know, I'm Senator Henry Ingerson, and I represent Senate District 32, which includes Arundel, Biddeford, Dayton, Hollis, and Lyman. Today, I'm very pleased to introduce LD 2065, an act to provide one-time funds to support the construction of a psychiatric residential treatment facility for at-risk youth. LD 2065 aims to fill an anticipated funding gap needed to complete construction of Maine's very first psychiatric residential treatment facility, serving at-risk youth under 21 years old. Construction will be centered around renovating an existing building rather than building a new one, saving additional costs. With over 70 Maine kids placed out of state, and over 100 more waiting to be sent out of state, and dozens languishing in emergency rooms with nowhere to go, getting this facility built will ensure families stay together through their treatment journey. It will also spare the state from paying millions and millions to send kids away from their families for treatment. While the financial savings to the state are very important, I would be remiss if I did not mention my serious concerns about the safety and well-being of Maine kids receiving treatment in some of these out-of-state facilities. In 2024, the Bangor Daily News reported on residential treatment facilities across the country. These facilities were the subject of federal investigation into their abuse and neglect. As one example, the report raised concerns about a pair of Acadia healthcare facilities in Arkansas, which Maine approved to serve kids in 2018. Further on, the article notes particular concerns for Maine children with disabilities. I think it's worth quoting due to the context, and I quote, "More youth started to go out of state as community-based behavioral health services eroded, increasing the likelihood that youth with behavioral disorders would escalate to a point where they were institutionalized in hospitals, residential facilities, and the state youth prison." The U.S. Department of Justice notified Maine officials in June 2022 that the over-institutionalization amounted to systemic violations of the Americans with Disabilities Act. With LD 2065, we can allocate the funding necessary to finish Maine's first psychiatric residential treatment facility, where we can keep kids close to their families and prevent them from ending up in questionable facilities far away. I want to thank this committee for its time today, and I'd be happy to answer any questions, but there are those that are going to follow me up that have more, I guess, a microscopic view of this facility that's going to be built. So thank you very much.
Thank you, Senator. Seeing no questions. Co-sponsors.
Good morning, everybody,
Welcome.
on this
Morning.
cold Maine morning. Senator Ingerson, Representative Meyer, and honorable colleagues of the Health and Human Services Committee. I am Lori Gramlich, and I have the privilege of representing House District 131, which is the lovely seaside community of Old Orchard Beach. And I'm also honored to serve as the Assistant House Majority Leader. I appreciate the opportunity to come before you today as the lead co-sponsor of LD 2065, an act to provide one-time funds to support the construction of a psychiatric residential treatment facility for at-risk youth. This legislation represents a critical and long overdue investment in Maine's behavioral health continuum for children and adolescents. As you've heard, Maine continues to face a severe shortage of in-state psychiatric residential treatment facilities, which is otherwise known as PRTF. Beds for youth under the age of 21 with complex behavioral health, psychiatric, and intellectual and developmental disability needs. As a result,
The state has been forced to place children in out-of-state residential treatment facilities, as the bill sponsor identified, often hundreds of miles away from their families, schools, communities, and care coordinators. These placements are disruptive, costly, and frequently result in poor outcomes for children who need stability, connection, and trauma-informed care close to home. This proposed one-time appropriation identified in this bill is a necessary step toward addressing this gap. Construction of an in-state psychiatric residential treatment facility will allow Maine to retain responsibility for its most vulnerable youth, reduce reliance on out-of-state placements, and ensure care is delivered in a manner consistent with Maine's values and standards. This bill is especially important in light of Maine's statutory and regulatory commitments. The Department of Health and Human Services was directed to implement secure children's psychiatric residential treatment facility services by January 1st, 2024, pursuant to Chapter 101 of the Maine Care Benefits Manual. The delivery model is required to provide secure behavioral health and intellectual and developmental disability PRTF services. Without appropriate physical infrastructure, compliance with these requirements is just not feasible. Capital investments is foundational to making these services a reality. The consequences of an inadequate system of care for children with significant behavioral health needs are often all too tragic. While no single facility can prevent every tragedy, the absence of appropriate, secure therapeutic residential options in Maine places children, family, and communities at unacceptable risk. This legislation represents a proactive, solutions-oriented response to those systemic failures. Importantly, investing in an in-state facility is also fiscally responsible. As you heard, out-of-state placements often come with higher per diem costs, additional transportation expenses, and limited oversight. I'll additionally go off script and add that it's compounding what families are going through having their children placed out of state. And you've heard me before this committee time and time again talk about, at least my perspective as a mom, having the empathy of what that must be like for a parent not to be able to have access to their children. Building capacity within Maine strengthens accountability, improves care coordination with Maine providers and child welfare systems, and creates a more sustainable long-term model. In closing, this bill is not simply about bricks and mortar. It is about fulfilling Maine's obligation to care for children with the most complex needs, keeping them close to their families and supports, and aligning our infrastructure with our policy commitments. I urge the committee to support this bill with this one-time funding to move this critical project forward. I appreciate your time and consideration and would be happy to answer any questions for you.
Questions? Yes, Representative Graham.
Thank you, Madam Chair. Thank you, Representative. Always nice to see you here.
Likewise.
Question is, do you have a sense that some of these kids are actually ending up in the criminal justice system? And for example, being placed in Long Creek where those services are obviously not capable of meeting their needs?
I appreciate the question. And while I don't have firsthand conclusive knowledge about that, anecdotally, I would say that there's probably an increased risk of that occurring. We know that right now we have there's about 46 kids that are placed right now in Long Creek. We have about 70 kids that are placed out of state receiving residential treatment, which we could certainly do within the state of Maine. While this facility can't meet the needs of every single one of those 46 kids potentially, and certainly the 70 kids placed out of state, it will certainly provide an opportunity to offer services for the most acute needs of these children. Mm-hmm.
Did I see your hand up, Representative? Go ahead.
How many beds would we secure with this funding?
I believe the folks from Sweetser can confirm this, but I believe it's targeted for 16 beds.
Seeing no other questions, thanks for being here.
Thank you very much.
Any other co-sponsors in the room that I can't see behind the? I guess not. So we will open it up for testimony in support.
Good morning. Senator Ingwerson, Representative Meyer, and members of the Health and Human Services Committee. My name is Justin Chenette, and I am the Chief Communications Officer at Sweetser. It's great seeing so many familiar faces I had the honor of serving with. Thank you, Senator Ingwerson, for introducing this bill and the many bipartisan co-sponsors, including Representative Meyer, Senator Moore, Representative Daigle, and Representative Gramlich. This committee, the legislature, and DHHS have provided real leadership in acknowledging the plight of families and the lack of in-state care for this vulnerable population. In 2024, when DHHS put out a request for providers to create Maine's first psychiatric residential treatment facility, only one answered the call. Sweetser stepped up to meet the moment, and after being awarded the RFP last year, have been working collaboratively with various stakeholders to make this a reality. This project represents a unifying solution to the pressing needs of Maine's most at-risk youth and reaffirms our shared goal of strengthening Maine families by keeping them together through the healing journey and being fiscally prudent with taxpayer dollars. By simply upgrading an existing building to this standard of care, we are saving the state the expense of building new. And long-term, there will be savings by keeping tax dollars local and without the expensive travel costs. So here's where we're at now. $2 million has been appropriated by the legislature as a down payment to start this program. $2.5 million will come from Sweetser. We are accomplishing this through daily fundraising efforts. We held a gala in the fall. We have a fundraiser Saturday. We have a radiothon next week and a golf tournament in June. When construction costs were increasing, Sweetser once again stepped up to the plate and increased our commitment to the project by $500,000. Sweetser is doing our part. This leaves $3.4 million needed to complete the $7.9 million project. Sweetser has also been actively trying to find cost savings wherever we can. We have been working with our construction partners to review every line item to brainstorm alternatives to bring costs down. Some of that has yielded to savings, but ultimately, there are things we can't compromise on, like safety, security, and creating a true therapeutic setting. Now, don't get hung up on the number in the bill today as we work to exhaust all potential funding options. For your work session, we will either have a clear number or come back not needing this legislation. Since the big game is coming up, I'll use a football analogy. With a few points needed on the board, all we need is a field goal from the department to find a funding mechanism. If we miss that, we need the legislature to score a touchdown to get this bill and get this project across the finish line. If neither one of those two things happen in the next few months, the game is over and this facility will not be created. Maine families from York County to Washington County to Aroostook County will continue to see their youth shipped halfway across the country for more expensive care without the natural supports of loved ones close by. So thank you for your time, your leadership, and your consideration.
And thank you for your testimony and enthusiasm.
Absolutely.
Any questions from the committee? Seeing none.
Oh.
Oh, there you go. And also introduce yourself, please,
Thank
Representative.
you. My name's Sam Zager. I'm honored to represent District 116, part of Portland. Thank you again for framing things. I may have missed something, but you described this breakdown of what's already been accumulated and what is planned. The fiscal note is 1.1 million. I don't see that number on these. How does that fit in? Is that part of the 3.4 million?
Absolutely. So I think as we are crafting this legislation with Senator Ingwerson, I think there was a lot of moving parts in terms of where the numbers were shifting, in terms of where resources were being allocated and what is available to us. So that's why I say don't get hung up on the number today. 3.4 million is the gap. We are working very collaboratively with DHHS. They've been incredible partners with us to try to find grant opportunities and other funding mechanisms. And so throughout this process, as you can imagine with any kind of construction projects, there's a lot coming at us in terms of how we're crafting this facility and making sure we're meeting the requirements of the RFP and the stringent nature of the security of this particular facility. It needs to be both secure but also therapeutic. So that's why I wanted to kind of give that breakdown. And again, the hope is to find other funding mechanisms. But if that is not the case, this bill is absolutely going to be needed this session.
And so follow. So this would be like another department of another division of the department, like Dorothea Dix or Riverview are currently.
So basically, with the appropriation that's already taken place, this would be in addition to that, in addition to our funding. So this would be just a one-time appropriation.
Okay.
Did that answer your question?
I may learn more as this proceeds, but.
Yeah, we have a couple folks that will be here to talk about both the clinical aspect, the impact, and then also break down what we're seeing as the major cost drivers that are really increasing the construction costs throughout this process.
Okay, thank you
Yep.
so much.
Absolutely.
Question from me, Justin.
Sure.
Ballpark, how long you need between the public hearing and the work session?
Oh,
in order
absolutely.
To,
That's a great question coming from the chair. It's like you want to schedule out what's
well,
happening.
yes. It'd be nice to know what,
Logistics.
what are we looking at here?
You know, I think the department might be able to answer that. I would say if you can give us a couple weeks, I think that would be really helpful. I think there's, again, a lot of moving pieces that the department might be able to answer related to other potential funding opportunities. I feel very confident in our work with the department that, you know, they're doing their due diligence, we're doing our due diligence. And so I would really view this bill as that backup. If we cannot obtain that 3.4 million and meet that gap, this is really that stopgap measure. So I would say a month would be nice, but a couple of weeks would give us some more flexibility.
Thank you.
Yeah.
Appreciate that.
Absolutely.
Thanks.
Yeah,
No
thank
other
you.
questions. Testimony and support.
I hate following Justin, just saying.
Welcome.
Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee, thank you for the opportunity to testify today. And thank you, Senator Ingerson, for sponsoring LD 2065. My name is Jane Van Bramer, President and CEO of Sweetser, and I'm here in strong support of this legislation. I'm here to ask for additional one-time funding and to explain why the projected construction costs for the planned PRTF are higher than the initial estimate and why those increases are necessary to ensure safety, compliance, and quality of care for Maine's most vulnerable youth. In 2024, at the committee's request, Maine's legislators included $2 million in the budget to support the renovation of an existing building to create Maine's first PRTF. That figure was an early internal estimate developed by Sweetser before we engaged an architectural firm or general contractor, before a detailed design and construction cost analysis was completed, and before the state's PRTF RFP was distributed. That figure also did not reflect the funds Sweetser committed to raising through philanthropy. Since that estimate was developed more than 2 years ago, construction costs have risen significantly. The industry has experienced sustained inflation. Tariffs have contributed to sharp increases in the cost of steel, lumber, mechanical systems, and electrical components. At the same time, shortages in skilled labor, particularly those in specialized trade, has driven up labor costs and extended construction timelines. These market conditions alone have substantially increased project costs. In addition, a PRTF is not comparable to a standard residential or commercial renovation. They require highly specialized design features to ensure safety and meet clinical standards. These include ligature-resistant fixtures, reinforced doors and windows, tamper-resistant mechanical and electrical systems, secure yet therapeutic environments, and enhanced HVAC systems to support air quality and infection control. These features are essential for protecting youth and staff and are required to meet standard. The facility must also comply with regulations, including life safety codes, accessibility standards, fire protection requirements, and behavioral health specific licensing criteria. These requirements are non-negotiable and apply regardless of the size of the facility. To operate safely 24 hours a day, the building requires robust mechanical, electrical, and plumbing systems, emergency power generation, security and monitoring systems, and fire alarm and suppression systems. Redundancy and backup systems also add cost, but they're critical to uninterrupted care. Site-related conditions have also contributed to increased expenses. Utility upgrades, grading needs, and unforeseen issues such as asbestos are common in this type of renovation project. Timelines have further increased our costs. It's important to note that these investments are not optional or excessive. In closing, our revised construction budget reflects the true cost of delivering a safe, compliant, and clinically appropriate psychiatric residential treatments facility. Supporting this bill and ultimately this construction is essential to ensuring that Maine youth receive high-quality behavioral health care in state they both need and deserve. Thank you for your consideration.
Thank you for being here today. Questions from the committee? I'm seeing none.
Yep.
Go ahead.
Hey, Jane, thank you.
Hi. Thank you.
I pretty much think I know what the answer to this is, but have you tried to work with the federal government in relation to getting grants or any monies to help support this project?
We are looking under every bed for funding. We are exhausting every resource. We're looking at all grantors. As Justin mentioned, the state has really been great partners with us too, in terms of trying to secure any kind of federal monies that might be available. We're hopeful that something's going to turn up. Fingers crossed, but this bill is in case we exhaust and in case we're not successful with all these other measures. But we are certainly looking, and we're doing pretty well with fundraising. This 2.5 million Sweetser has committed to raising is a big number. But we've had our most successful auction and gala to date. We've had 2 golf tournaments so far. We're doing pretty well with raising money. The people of Maine understand and want this service for our children.
Thank you.
Thank you.
I'm sorry, can we move the flowers back just a little bit? Sorry about that. Go ahead, Representative.
This will provide 16 beds, and we know the need is greater. So with this particular project, has there ever been any thought to a potential to adding on in the future where the cost would probably be reduced because of what's been done to date?
So the footprint of this building will support 16 beds. So in terms of adding on to this building, that's probably not feasible. But I do think, once we demonstrate the success of this and the cost savings of it, which there will be, just given what we're spending now for out of state, for hospitalizations, for kids languishing in ERs, that there might be, another PRTF in Maine's future.
Would be potential to add a wing to this, because I know if you can combine facility space, it makes it more efficient.
It does, but I also think there is some downside where you get to be too big of a facility where it becomes more institution-like. We want this to be therapeutic and home-like, which is why we limited it to 16 beds, and that was the request of the state. But there are pros and cons to consider down the road on that. But you're right, there could be a wing added on, and then we would have the mechanical and the back, office kind of stuff already completed. Thank you.
Testimony in support of the bill. Go ahead.
Senator Ingerson, Representative Mayer, and members of the Health and Human Services Committee. My name is Christy Worcester, and I am the Chief Program Officer at Sweetser. I am a licensed clinical social worker and have been working in behavioral health in Maine for 19 years. I'm here today to testify in support of LD 2065 and to underscore the critical importance of one-time funding to support the construction of the PRTF for at-risk youth. The PRTF will be the only facility of its kind in Maine, providing the safety of an inpatient setting within a residential environment, reducing stigma, and supporting a smoother transition back home for children served in this setting. An 8,000 square foot, 16-bed facility, the unit is staffed with a full-time medical director, a clinical director providing 24/7 psychiatric nursing, clinical coverage with crisis staff, CNAs, and behavioral health professionals. Children will spend 6 to 9 months receiving the right level of care at the right time, close to their families and communities. No longer will our children be sent to facilities in Georgia and Arkansas and beyond. No longer will they remain in inpatient units or emergency departments for months while awaiting appropriate care. The PRTF will typically serve children around ages 10 to 18 who require a secure setting for their own safety and the safety of others. These young people may experience suicidal behavior, aggression, attempts to run away, and other highly dangerous behaviors. They may have trauma-related diagnoses, mood or psychotic disorders, or personality disorders. This facility will serve youth and families in every corner of Maine from all 16 counties. Treatment is highly structured and intensive, designed for youth with the most severe psychiatric illnesses. Services will include care for co-occurring substance use disorder, youth with problem sexualized behavior, and children with secondary developmental disabilities. In addition to safety and stabilization, treatment will focus on facilitating a successful transition back home. PRTFs ensure the highest level of quality, safety, and regulatory compliance. The facility will be accredited by the Council on Accreditation, comply with federal conditions of participation under CMS, and be state licensed. Each require rigorous standards and measurable outcomes. As we work to see this project through to completion, cost savings ideas such as reducing the facility from 16 to 18 beds were explored. Ultimately, we found that this would not produce meaningful outcomes. Most expenses are fixed and driven by safety, regulatory, and licensing requirements, like others have mentioned, not by bed count. The same life safety systems, HVAC, security, emergency power, and clinical support spaces are required regardless of the unit size. Downsizing would significantly reduce capacity, increase the cost per bed, and provide only limited savings. Every day that passes is another day without treatment for so many children in Maine, and I urge you to approve the one-time funding for the PRTF so we can begin this vital work as soon as possible.
Thank you. Questions from the committee? Seeing none. Okay, testimony and support.
Chair Ingerson, Chair Meyer, and members of the Health and Human Services Committee. My name is Bob Staples. I'm the president of the Brett M. Staples Brain Disorder Awareness Coalition, and I'm here today in strong support of LD 2065. This bill addresses a reality Maine can no longer work around. We do not have enough appropriate therapeutic residential capacity for youth with serious brain disorders who are already at risk. When care does not exist at the right level at the right time, children fall through gaps that quickly become lifelong consequences. Families are left cycling through emergency rooms. Youths are placed far from home, sent out of state, or held in settings that were never designed to treat complex brain-based conditions. And far too often, the first placement becomes the juvenile justice system, not because of criminal intent, but because care failed to show up. LD 2065 is not about expanding institutionalization. It is about building the missing middle, a therapeutic residential option for youth who are too ill to be safely treated at home, but who do not belong in hospitals, detention, or adult systems. This funding is one-time, targeted, and practical. It invests in infrastructure that Maine has lacked for years, even as need has grown, and it recognizes something critical. Early appropriate treatment changes trajectories. When serious brain disorders are addressed in adolescence with stability, continuity, and clinical expertise, outcomes improve, not just for the child, but for families, schools, and communities. From a system perspective, this investment also makes fiscal sense. Residential treatment capacity reduces repeated emergency department boarding, law enforcement involvement, hospital readmissions, and costly out-of-state placements. Inaction is not neutral. It is expensive, disruptive, and harmful. I would urge the committee to ensure that any facility supported under this bill emphasizes developmentally appropriate trauma-informed care, family engagement and continuity, coordination with education and community-based services, and to me, very importantly, a clear pathway back to the least restrictive, more supportive environment possible. This bill sends an important message to Maine families. Your children are worth building for. LD 2065 does not claim to solve everything, but it makes a meaningful, responsible step towards a system that treats youth brain health as urgent, real, and deserving of investment before crisis becomes destiny. I respectfully urge the committee to support LD 2065. Thank you for your time and your commitment to Maine's children and families.
Thank you, Mr. Staples. Questions from the committee? Seeing none. Testimony in the room in support?
Good morning.
Morning.
Senator Ingerson, Representative Meyer, and honorable members of the Health and Human Services Committee. Thank you for the opportunity to speak. My name is Dr. Deirdre Burns. I'm a pediatrician practicing in York County, and I've also practiced in Cumberland County in the past. I'm speaking to you in support of LD 2065 because I personally have witnessed the distress of families seeking inpatient psychiatric placement for their children. These children are in dire situations who are not safe to return home, and they may wait days or weeks, months, years, seeking a bed. I personally have cared for children waiting in the emergency department for an inpatient psychiatric bed. More recently, I had a patient wait 2 months in a windowless room in the ER. Imagine a child in your life in crisis, desperately in need of high-level psychiatric care, and made to wait days, weeks, months in a windowless room or in a windowless hallway waiting for that help. While waiting, these children receive supportive care from doctors, nurses, social workers who want nothing more than for that child to be in a therapeutic setting where they can heal and make progress. These inpatient psychiatric beds are elusive and scarce, creating uncertainty as to when or if the child will be lucky enough to be placed. Hours and hours of case management time is spent making calls to various facilities, getting on the wait lists, calling back every day to let them know we still want the bed, and again calling later that day to find out if we got the bed. One argument against this bill is that children should be at home and not in a residential facility. I see parents who would love nothing more than to be able to have their child at home, participating in outpatient intensive services, but their child is a threat to the safety of themselves, their family members, or the community. I've witnessed the heartbreak of parents who are unable to provide round-the-clock safety watch for their child because at some point the parent has to sleep or earn a living for their family. I've seen parents who have to put the safety and well-being of all the children in the home first. I've spoken to parents who are physically overpowered by a child who is a threat to themselves and others. I've seen parents who have secured the funding for in-home caregivers, but cannot find anyone to fill the position. A good day in Maine will be when we can't fill all our pediatric, inpatient, or residential psychiatric beds. I don't anticipate that day coming soon. Until then, we need more resources for these children who have the most need. And I ask that you vote ought to pass on LD 2065 and approve funding to construct a new psychiatric residential treatment facility for at-risk youth.
Thank you, Dr. Burns. Questions from the committee? Seeing none. Thanks for being here. Testimony and support here in the room?
Senator Ingerson, Representative Meyer, members of the committee, Happy New Year. This is my first time before the committee this year. You've heard a lot of the history about this bill and PRTFs, but we've been talking about it for 8 years and we still don't have the service. And the situation in our emergency departments and at Spring Harbor Hospital have not improved in those 8 years. Being passed out right now is my testimony, but also a recent study that was published in JAMA that found that Maine is the third worst state in the country in terms of children with Medicaid coverage that are boarding in hospital emergency departments with behavioral health needs. At Maine Health, 284 children languished in our emergency departments last year for longer than 48 hours. That number really has not changed over the years. We had one child this past year who lived in a rural emergency department for 3 months. And as you heard from the physician, and as you have heard many times, these are not therapeutic environments for our kids. And this is not a crisis that's just impacting our emergency departments. It's also impacting Spring Harbor Hospital. You heard from my colleague, Dr. Roz Gerwin, earlier this week, and she shared that at Spring Harbor in the past few months, we admitted 7 youth whose inpatient stays exceeded 120 days, and then one of whom, who is still there, who has been hospitalized for 300 days. They're all awaiting residential placement. At one point, these patients accounted for approximately 33% of our adolescent census, and at one point, even worse than that, more than 50% of the pediatric census. You have taken many important steps over the years to finally stand up this service. We hope that this will be the final step to finally ensure that this service is available for our most vulnerable youth. I urge your support, and I'd be happy to answer any questions that you may have.
Thank you. Questions for Ms. Calder? Seeing none.
All right,
Nice
thanks
to
so
see you. Any more testimony in the room in support? We've got some folks on Zooms. Morning, welcome.
Good morning. Thank you so much for having me. Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I'm Beth White. I'm the Director of Politics and Legislation for the Maine Service Employees Association, Local 1989 of the Service Employees International Union. We're a labor union representing over 13,000 Maine workers, including workers at the Department of Health and Human Services and the Department of Corrections. And we're here today in support of LD 2065 and want to thank the sponsor, co-sponsors, and members of this committee for the work that you've been doing to address the challenges that our workers are facing at OCFS. And I apologize for not being there in person. I'm feeling a tiny bit under the weather and figured I'd spare you all from any potential germs.
Thank you.
I did submit my testimony online, so I won't read the entire thing because it's a bit lengthy, but just want to hit some key points. As you all are very aware, there's been an ongoing crisis within OCFS of children being placed in either hotel rooms or emergency rooms for extended periods of time, mainly due to the lack of alternate placements and foster homes for them. As one of our MSEA members, Bernice Bunny Wermanchuk, said in her testimony on the budget last session, hoteling is not in the best interest of any child. Hoteling offers no stability, structure, or security. There's no privacy or sense of belonging. Without a place to cook or refrigerate food, meals provide no nutritional benefits and offer no ability to learn life skills. Hoteling and ED covering is also the #1 cause of burnout among OCFS staff with a high caseload. So we feel that, passing and funding this legislation will help address those issues, which often stem from that lack of long-term placements and solutions for children, such as a psychiatric residential treatment facility. Our members are very concerned about the wait times between when some children are discharged from acute care, such as the hospital room, or when they're remaining in that facility, to when a bed is actually available for them, because there simply are not enough beds to meet current needs. And so we feel that passing and funding this legislation would help make significant progress on that issue. Our members would also like to note that while this legislation is a key piece of the puzzle, they also feel that there are kind of 2 other additional needs outside of building a new PRTF that should be addressed. One of those is the need to increase the number of enhanced therapeutic foster homes for children with behavioral health needs. There are many examples that could demonstrate this need, such as a child with severe behavioral health needs, including nonverbal and self-harm behaviors. And in these cases, there's the concern about the wait time between when the child is discharged from acute care to when they can move into a bed in a PRTF. While obviously addressing the need for that end placement would do a significant amount, having those licensed intensive therapeutic homes for the interim situations would also be very helpful. And they also would like to highlight the need for placement of children who are waiting for permanent placements in a residence, such as a bridge home, which would offer more education, structure, nutrition, socialization, etc. Children can be discharged from an acute treatment facility, such as a hospital, and their condition might be stable and not needing treatment beyond outpatient therapy and community support. But these children might remain without a residence if that home is not available. And often those kids may end up in a hotel setting until they can find a solution. So all that being said, we are here in strong support of 2065. Our members are really eager to see more details as this moves forward. And at the bottom of the document, I've included, I think, a document you have all seen
We've
many
exceeded
times.
3 minutes.
Oh, sorry. I will wrap it up there and happy to answer any questions.
Thank you. Appreciate it. Questions from the committee? I'm seeing none. Have a
Thanks
good
so
day.
much.
Welcome. You're on mute.
Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. My name is John McAnuff, and I am Sweetzer's CFO. I am here today in support of LD 2065 and to express Sweetzer's interest in participating with the state to expand in-state psychiatric residential treatment capacity. As you know, Maine currently lacks psychiatric residential treatment facility, or PRTF capacity, for youth with the most acute behavioral health needs. When appropriate in-state care is unavailable, children often languish in hospital emergency departments or are placed far from home, sometimes out of state. These options are disruptive for families and significantly more expensive for the state. Sweetzer has extensive experience operating intensive residential and psychiatric services. That experience has taught us two things. First, there is a clear clinical need for a PRTF in Maine. And second, these facilities are expensive to build, not because they are elaborate, but because they must be safe. Youth served in a PRTF present higher risks related to elopement, self-harm, and harm to others. As a result, the building itself becomes part of the treatment and safety plan. Construction costs are driven by requirements such as ligature and tamper-resistant fixtures throughout the residence, complex access control and egress systems, including secure entry vestibules and remotely controlled exits, continuous monitoring and security systems, including specialized anti-climb fencing for outdoor spaces, reinforced interior construction designed to withstand damage while protecting residents and staff. In addition, these facilities require infrastructure enhancements, including upgraded electrical service with full generator backup, specialized ventilation and cooling systems because operable windows are unsafe, fire protection upgrades, and full ADA accessibility. Many components also require specialized installation methods, which significantly increases labor costs. Sweetzer has been intentional about cost containment. This project reuses an existing building on our campus rather than pursuing new construction, which would likely exceed $10 million. We are retaining usable systems, selecting modest finishes, and making design choices that reduce cost whenever safety allows. Even so, the clinical and regulatory requirements of a PRTF create unavoidable capital expense. LD 2065 is important because it recognizes that these kinds of costs are a major barrier to expanding PRTF capacity. Without state partnership, nonprofit providers cannot assume this level of financial risk, and these facilities will not be built. Sweetzer is interested in working collaboratively with the state to develop a PRTF that keeps children closer to home, reduces reliance on emergency departments and out-of-state placements, and fits within Maine's broader continuum of care. We view this as a partnership that must balance clinical quality, safety, and long-term sustainability. LD 2065 is a thoughtful, targeted investment in Maine's children and in Maine-based solutions. I respectfully urge the committee to support this bill. Thank you for your time, and I would be happy to answer any questions.
Thank you. Thank you for being here. Questions from the committee? I'm seeing none. Oh. Hi, yes, it's the flowers. Representative Zager.
Sorry, thank you, Madam Chair. Which campus would this be? There's several for Sweetzer.
So this would be on our Saco campus on Moody Street.
Okay, great, thank you.
Thanks for being here, John.
Okay, thank you, folks.
Welcome, Lisa.
Sure. Good morning, everyone. I appreciate the opportunity to join you on video. Senator Ingerson, Representative Meyer, committee members. My name is Lisa Harvey McPherson, and I'm here today on behalf of Northern Light Health to speak in support of this bill. The challenge of youth in our emergency department is a challenge that we all have worked together on for many, many years. And the bill before you today represents the opportunity to be very, very close, to get this facility over the goalpost and provide this level of care for our children. In 2025, 153 youth were in a Northern Light Health Emergency Department for longer than 48 hours. On average, they were in our emergency department for 5.6 days, and the longest youth length of stay was 29 days last summer. This is an issue that impacts emergency departments, large and small. The greatest number of youth are in our tertiary facility emergency department, Eastern Maine Medical Center. That was 88 youth, but 27 youth lived in a small emergency room at Mayo Hospital in Dover Foxcroft, and another 17 lived in our emergency room at A.R. Gould in Presque Isle. These are very small emergency rooms, and as much as we do to support these children in those challenging environments, they are exposed to the full array of what occurs in an emergency department. And only our licensed physicians and nurses are trained to witness those challenging care situations. Acadia Hospital is also impacted. When I had a conversation with our director of pediatric inpatient care, and what she described to me is children in Acadia kind of have therapeutic interventions, and they reach a peak. They reach a clinical peak of what an inpatient environment of care can do for them, and they're ready for discharge. And as they watch these children linger in the wrong environment, they deteriorate. And so while we are working hard to support these children in whatever level of care they're in, the emergency department or Acadia Hospital, the wrong level of care doesn't meet their needs. I want to answer a question that came up earlier this week on another youth residential care bill, and that has to do with the emergency department, and it has to do with funding. But I want to say the moral distress to our staff is real. It's very, very real to watch these children languish, and it's been going on, unfortunately, for a long time. When a child presents to the emergency department, we provide a clinical service, and that child is clinically cared for until they are medically cleared for discharge. When that child is medically cleared for discharge, there's no funding opportunity for that child in the emergency room department. So we'll bill up front for a doctor fee, maybe a lab fee. They're medically discharged, and then they wait. There's no days awaiting placement per child, payment for a child in the emergency department. We did submit comment on a rule this fall to the department asking for a days awaiting placement, and the department declined that request from Northern Light, Maine Health, and MHA. So I
Lisa.
just wanted to share that, since that did come up on a related bill caring for these youth earlier in the week. And I am out of time, and I welcome any questions that you have.
Thank you. Questions for Lisa Harvey McPherson? I'm seeing none. Thanks for being here.
Thank you.
No one else? One in opposition? Yeah. Okay, why don't we bring John up now? So we'll turn to testimony in opposition to the bill.
Hello.
Good morning, John.
Good morning. Senator Ingerson, Representative Meyer, and the members of the Health and Human Services Committee. I am against this bill all entirely. I don't want to feel like we are going backwards. Building an institution-like setting. People, including youth, should be cared for and taken care of in their communities. I would prefer to see the money used for this to go towards providing greater services to young people in their communities.
Is that it, John?
That's it.
Oh, short and sweet. We're always happy to see you.
I always leave it that way.
Thanks for your testimony. Any questions from the committee for Mr. McGovern? Hope to see you again soon, John.
See you guys.
Anyone else in the room with testimony in opposition? Testimony neither for nor against. Questions for or requests for additional info from our committee members for our analyst? Seeing none? Oh, go ahead.
How much do we spend for out-of-state placements for 16 people relative to what we spend for in-state? We see our potential savings. And do we have adequate workforce?
Someone come up and answer that now or wait for the work session?
I think we can wait for the work session. Yeah. Looks like that's it. So I will close the public hearing on LD 2065 and open the public hearing on LD 1996, also presented by our own Senator Ingerson.
Good morning again, Representative Meyer and fellow colleagues on the Committee on Health and Human Services. I'm Senator Henry Ingerson, and I represent Senate District 32, which includes Arundel, Biddeford, Dayton, Hollis, and Lyman. Today, I'm pleased to introduce a bill on behalf of the Department of Health and Human Services, LD 1996, an act to clarify responsibilities of the state in laws governing general assistance. I've sponsored this bill on behalf of the Office for Family Independence, an office within the Department of Health and Human Services, of which we are all familiar. This bill removes the specific requirement that DHHS provide overseers of each municipality's general assistant program access to internet-based real-time data containing the information necessary to properly determine eligibility of an applicant for GA. The bill also updates certain reporting requirements for the department. I know that all of us in this room have a shared desire to improve the availability of data and information regarding the usage of our GA program. It has been a focus of this committee, and I know that it will continue to be. When the legislature voted in the first session of the 132nd to approve this specific provision, the separate but accompanying policy that would have provided the necessary appropriations was not approved. As we've heard from the department, and I'm sure they will reiterate this point following me today, the establishment of an online database is simply too costly. The removal of this requirement will ensure the department is not out of compliance with this statute moving forward. I hope that you'll join me in supporting this bill. The department will follow my testimony, and I ask that you please hold questions you may have for the department. Thank you.
Thank you, Senator. Welcome, Director.
Good morning, Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Ian Yaffe, and I serve as Director of the Office for Family Independence in the Maine Department of Health and Human Services. I'm here today to testify in support of LD 1996, an act to clarify the responsibilities of the state in the laws governing general assistance. The department appreciates the legislature's intent in establishing a statewide general assistance database and enhanced reporting requirements, and we ultimately share the goal of improving the availability of data and information regarding the usage of the GA program. At the time the statutory requirement for the provision of a statewide database was enacted, the department believed it could absorb the expense to implement the necessary software and did not anticipate the level of costs required to build and maintain a secure statewide system for a municipally administered program. In August 2024, we launched an RFP to build a technology platform for this system. And the bids that we received ranged from 752,000 to 5.8 million for the initial performance period, which was 2 years. As planning progressed, it became clear that the scope and cost of a statewide general assistance database exceeded what the department can reasonably absorb within current funding. As a result, the department is now faced with a statutory requirement that cannot be fully implemented with current resources. And given this current fiscal reality and the ongoing increases to the costs within the GA program, we cannot absorb these costs into department resources as originally intended. Based on this financial reality, the department proposes to repeal the requirement for the department to provide the database and to slightly modify the reporting requirements for the department based on what we can report without the database, using changes that we already implemented to the GA reimbursement form effective July 1st of last year, which will enable a partial report to this committee in the coming weeks. This bill provides a narrow technical correction by removing the unfunded database mandate and relating reporting requirement, bringing statute back into alignment with what can be operationally and fiscally supported. The department also wants to clarify the legislative history of this issue. In the prior session, the legislator voted to approve this change to address the lack of a GA database system and funding. However, that provision was coupled with separate policy changes in LD 978 that carried a fiscal impact. As a result, while the policy language advanced, the necessary appropriations did not pass. This bill, LD 1996, separates the narrow technical correction from broader policy considerations in the General Assistance Program, allowing the legislature to address this issue independently and prevent ongoing statutory noncompliance. The department supports this bill and remains committed to transparency and accountability within the General Assistance Program. We respectfully request the committee's support of this bill as a standalone measure to prevent continued noncompliance and allow the department and legislature to revisit system modernization in the future if funding becomes available. Thank you for your time and attention, and I'd be happy to answer any questions you have today or at the work session.
Thank you, Director Yaffe. Questions from the committee? Yes. Was that a question? No. Yes.
Thank you, Madam Chair. So, once this is implemented, how are you going to be able to track data from municipalities, and how are you going to be able to support municipalities?
Thanks for the question. We don't currently have a database, so there isn't. When this is implemented, we will have what we have today, which is no database. The data that we use to track at the department level, the data that we use to track utilization in the General Assistance Program comes from the typically monthly reimbursement forms received from municipalities and tribes. And the changes that we made to those forms over the summer were to add some new fields to get the question of how many individuals are served by each municipality or tribe each month, and to get a running total for the fiscal year so that we can report to this committee the number of individuals deduplicated within municipalities that are receiving assistance from the program. But better reporting and better tracking ultimately will require a database, and that database will ultimately require funding that is not currently available. And so that's the reason why we propose this bill, and the reason why we're seeking the committee's support is to align that decision again in the future with if resources are available. Thank you.
Thank you.
Thank you.
Testimony in support of the bill? Where's mine? That's against. Testimony in opposition?
Good morning.
Good morning.
Happy New Year. It's nice to see you all again. Senator Ingerson, Representative Meyer, distinguished members of the Joint Standing Committee on Health and Human Services. My name is Amanda Campbell, and I am submitting testimony in opposition to LD 1996 on behalf of the Maine Municipal Association's 70-member Legislative Policy Committee, or LPC. LD 1996, as you heard, proposes to repeal the sections of Title 22 that provide an internet-based real-time database containing the information necessary to properly determine an applicant's eligibility to general assistance administrators. Maine Municipal Association has advocated for reforms to the GA program for several sessions, including a platform bill during the 131st legislature that included a provision for a statewide database. Department testimony from April 2025 in response to public hearings on several GA bills noted that several bids for technology platform initial programming had been received through the RFP process, and the department continued by explaining those costs could not be absorbed under the current fiscal conditions, and that a bill would be forthcoming to, quote, clarify what it can accomplish or to delay the system until funding is available. Considering the department's previous support for the database and a willingness to postpone implementation of the directive, municipal officials were surprised that the promised clarity ultimately took the form of a proposal to repeal this requirement. During discussion of this bill, LPC members used words like essential and critical in reference to the database to aid not only in streamlined administration of this program, but for increasing transparency, reducing error rates, and discovering potential fraud. One member described the database as the most important tool needed next to increased reimbursements. A GA database is the most meaningful, cost-effective, and attainable improvement that is necessary for administrators to provide the state policy at the municipal level. Municipal officials asked the committee to continue to pursue this initiative, and LPC members encouraged the committee to consider amending implementation dates in statute to allow the department and stakeholders to evaluate potentially viable options and possible solutions. GA administrators play a key role in the state-local partnership and want to provide the aid for which applicants are eligible while also preserving the integrity of the program. They need the appropriate tools to do so. It is for these reasons that MMA offers the solution outlined below, which seeks to strike a balance between the department's current budget constraints, but keeping implementation of the database in view. And you'll see down below, we're simply suggesting moving the implementation date out to allow for that continued conversation and protect it within statute. Thank you for your consideration of the municipal perspective. This is an important topic, and please feel free to contact me, any member of the LPC or the MMA advocacy team, with any questions relating to municipal operations. Thank you.
Thank you, Ms. Campbell. Questions from the committee? I'm seeing none.
Thank you very much.
Ongoing testimony in opposition.
I submitted online, so I don't have any written at the moment.
Thank you, Dina.
Never put my laptop up here, so it might be a little adjustment. All right. Good morning, Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. My name is Dina Mulwell, and I'm a policy advocate with Maine Equal Justice, a nonprofit legal aid provider working to increase economic security, opportunity, and equity for people in Maine. Maine Equal Justice, as many of you know, has worked on general assistance since we were founded in the mid-90s, and some of our staff has worked on it for more than 40 years. So we have a lot of experience with advocating for an improved GA program. Today, I stand here asking you to reject LD 1996. In the 131st session, with leadership from this committee, the legislature passed LD 1732, which took several steps to improve GA, including the creation of this database that we're talking about today. Beginning July 1st, 2025, the department would have used information from this real-time internet-based database to improve GA eligibility and determination. Despite the enactment, the database was never created. In testimony last year on LD 637, which was duplicative statutory requirements passed in LD 1732, the department opposed LD 637 and cited high costs for the database delay. A request, as you heard the department share, RFP was then launched to build this technology platform for the GA program, and bids range from $670,000 to $3.7 million, increasing the following years, which the department felt was too costly. As you know, this committee ultimately decided to amend another bill last year to repeal the database requirement. However, that bill died. So today, LD 1996 would repeal the database requirement and remove the requirement for the department to report on the length of time individuals receive assistance. While this bill aligns with actions this committee took last year, we still ask that you reconsider. General assistance is needed now more than ever. At a time where state and federal program eligibility is narrowing and living costs are increasing, the demand for food and shelter is dire. The database Database and reporting requirements were introduced in 2023, and this year we will finally have more accurate and comprehensive data to support policy decisions, but it will be incomplete. While we understand the cost challenge of creating a new database, we believe that the database is vital to ensure effective administration. We also believe maintaining information about the length of time individuals or households receive assistance is important because of recent proposals to limit the period of time people can access assistance. How can we understand the implications of such a change if we don't have the data about it? For these reasons, we ask that the committee delay the database rather than repeal it. Reporting without consistent data will be incomplete. A database can help ensure that we have a full picture about the individual and families who will receive GA, the length of time the assistance was received, and the type of assistance received. While cost concerns are real and the choices legislators can make to ensure we have adequate funding both for assistance GA provides and for transparent administration of the program, which should include a database. Thank you for this opportunity to come in. I'll take any questions. Sorry, I'm wearing my retainer, so I might have a bit of a lisper.
Thank you for being here today. Any questions from the committee? Seeing none. Testimony in opposition?
Right. Good morning, Senator Ingerson, Representative Meyer, and honorable members of the committee. My name is Dr. Katie Spencer White, and I'm the president and CEO of the Mid-Maine Homeless Shelter and Services in Waterville. I'm here today really to offer some field notes of what it is like working in the field of homelessness, which is closely aligned with our municipal general assistance operations. And I want to highlight two instances of where this database is crucial. Very often when practitioners such as myself come to the legislature requesting funding, as we do every single session, one of the key things that is asked of us is, what's the impact? How is this going to move the needle? How are people going to be better served by an allocation of resources? And what I can tell you as somebody who does research or tries to do research on general assistance, 2 years ago, I conducted a collaborative research project with Colby College to assess the quality and effectiveness of case management services for people experiencing homelessness. The vast majority of the data that we require lives in more than 400 municipal spreadsheets. It's very difficult for researchers in the absence of centralized databases to collect anything to demonstrate either to this body or to the taxpayers of the state how effective and how efficient the utilization of taxpayer dollars are. I also want to note that one of the key issues that we as homeless service providers confront as people who are in emergencies, and importantly, presumptive eligibility. We have heard consistently that presumptive eligibility is utilized primarily by Portland. The reason for this is we lack consistent information about things like denials, how quickly we can assess people for their eligibility. And in the absence of that centralized data, again, we're relying on really analog 20th century systems that are not fit for purpose. Perhaps they were in 1998 when our homeless crisis was not as acute as it is today. But in 2026, we really need these real-time information systems so that we can better meet the moment. So without further ado, I'm happy to take any questions. And again, I fully endorse what my colleagues have previously said. Please, please stay the course and make sure that we have central real-time data so that we can better serve people experiencing homelessness, people in crisis, and the taxpayers of the state. Thank you.
Thank you. Questions from the committee? I'm seeing none.
Thank you.
Appreciate you being here. Anyone else here in the room with testimony in opposition? We still have someone, yeah. Why don't you bring them on board? Welcome.
Hi, is that me?
That is you. You can get
Thank
started.
you.
We're running a 3-minute clock.
Okay. Senator Ingerson, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Paige Kumbakis, and I'm submitting testimony in opposition of LD 1996 on behalf of the Maine Welfare Directors Association Executive Board. Implementation of statewide database remains a critical need for general assistance administrators around the state. A comprehensive database has the potential to reduce administrative error rates, fraud cases, and could increase data reporting accuracy to the department. Maine Welfare Directors Association remains committed to ensuring efficient, standardized, and equitable administration of the General Assistance Program throughout the state, and a statewide database is one of the tools that we believe has the potential to assist in that mission. The department previously indicated their own interest in implementation of a database when they were approached earlier this winter with a proposal from a software company working on a pilot database. We were hopeful that we would see a resolution to this matter. However, the department declined the proposal, again, citing budgetary restrictions, despite a proposal that was well below previous bids and was already in early development stages. Investment in a database would mean availability of statewide data that could be used to inform future policy and funding decisions for the General Assistance Program. While data-driven decision-making is becoming commonplace in public policy spaces, there is a stark lack of reliable or timely data available for the General Assistance Program. It is for these reasons that the MWDA Executive Board urges the committee to vote ought not to pass on LD 1996. And an elimination of the database required by statute would be a disservice to municipalities and administrators throughout the state, our applicants and taxpayers. Thank you.
Thank you. Questions from the committee? I'm seeing none. We appreciate you being here today. Testimony neither for nor against, but with additional information for the committee. Questions or requests for additional information from our analysts? Yes, Rep. Zager.
Thank you, Madam Chair. I'm interested in a little bit more information from the department as to what was unsatisfactory about the lower end bids.
Yes, Representative Daigle.
There was a mention about an amendment that would have postponed the timeline to 2028. I would like that. I think if it's a feasible thing, would give us time to work at it.
Thank you, Representative. Okay, so we'll close the public hearing and yeah,
12:15.
we'll be back here on mic at 1.
Good afternoon. Welcome to the Health and Human Services Committee. We have a lot to do this afternoon. I'm going to start with committee introductions, and I'll begin over on my right with Representative Graham.
Thank you, Mr. Chair. Good afternoon. I'm Representative Annie Graham. I serve the people of North Yarmouth and the majority of Gray, House District 105, and I already did my weather report.
I'm Representative Lucian Daigle. Welcome here. Representing House District 1, the northernmost part of Maine. And I guarantee it's no warmer up there.
Hello, good afternoon. My name is Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Hello, my name is Sam Zager. I represent District 116, part of Portland.
Hi, I'm Michael Lemlin. I represent House District 53, Chelsea, Randolph, Pittston, and Dresden.
Good afternoon. I'm Representative Dan Shigori. I represent House District 55, the communities of Hollowell, Manchester, and West Gardner.
Good afternoon. My name is Julie McCabe. I represent District 93, part of Lewiston.
And Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levant, and Candace.
Welcome. I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, and parts of Kittery and South Berwick. And I'm honored to serve as this committee's House Chair.
And I'm Senator Henry Ingwerson, representing District 32, which is the city of Biddeford and Arundel, Dayton, Hollis, and Lyman down in Southern Maine. And this afternoon, I want to introduce our committee analysts, Anna Broom, and our committee clerk, Sophie Dubik. Thanks for being here as always. We have work sessions later this afternoon, but first we have two reports to the committee. And the first one is the Measuring Gaps in Home and Community-Based Services presented by Karen Lee Harrington. Come on up. Thank you. Just go ahead and introduce yourself and get started.
Good afternoon. My name is Karen Lee Harrington, and I am the Executive Director of the Maine Health Data Organization and the Maine Quality Forum, and I'm excited to be here in front of you. I know you have a packed full agenda, so I'm going to move through this quickly. I did not put together a PowerPoint because I said to myself, we put a lot of work into this report, and we tried to make it very like telling a story, starting at the beginning and working our way to the end with a recommendation. And so if okay with you, I think you all have copies. I'm going to go ahead and just walk you through it. And before I get into this, I want to just remind you, because you've got so much going on, the reason for the resolve, what is in the preamble that is why we're here today, is continuing workforce challenges have contributed to a gap between home and community-based services that are authorized and those that are delivered under the Maine Care Program and states funded programs. And consistent measurement of this care gap is critical to understanding whether the gap is expanding or contracting and whether policy interventions are needed. And the fact that the federal government is requiring some measurement around services that people are getting for community and home-based. So why am I here? Why is MHDO here, right? My organization is solely, our primary role is to create a comprehensive healthcare database. We've got over 1 billion healthcare records, and a lot of that information is sensitive data. We've got all kinds of security, and we've been operating for decades. And I'm happy to say we've had no breaches. We are like Fort Knox. And one of the things that I've been working with the organization now for over 13 years is we have got to, it's hard to do this in government, but we have got to be nimble as people's needs change for data and information. We've got to be able to figure out how to bring that data and information into the organization and then turn around and make it available to you all for your discussions around what to do, how to address problems that impact the folks of Maine. So MHDO has the experience. We are uniquely positioned to look at this and figure out, are there ways to collect this data to measure what in the resolve is defined as the care gap? So putting that aside, I'm going to now look at the report that you all have copies of. And just quickly, if you turn to the page after the cover page, you've got the table of contents. And I just want to quickly run through this because there's an overview in the report. Then there's a quick little summary on the federal requirements. There are some links if you're interested in more of the detail. And then the way we've dealt with this is we broke the resolve down into two parts. In the resolve, there's a whole bunch of sections of policy and main care, and with the Office of Aging and Disability. And I think that acronym is it ODS? And so right here. So we broke things down by what is in the resolve, those sections that are under OMS, and then those sections that are under ODS. And you'll see with each section, we have a recommendation. And then there are some additional supporting documentation in the appendix. So I'm going to jump into page 3. And again, the purpose of the resolve, bottom line, was for the Maine Health Data Organization to essentially look at how we could measure the care gap. And the care gap is defined as the difference between the home and community-based services that individuals are authorized to receive versus the actual services that they get. And again, it focused on these specific sections of policy that include coverage for home and community-based services. So that's the link. And so I want to just acknowledge that the Department of Health and Human Services, they reviewed all of this. They helped us tremendously as we tried to peel back this onion. Because the first thing that my instinct is, everything needs to be standardized. If you're going to collect data, you want it to be standard so that you can compare and measure, right? And so first, before we could even get into all of that, we needed to understand, well, what is the state of the state right now? Like, how does this all work? Who's involved? What systems are used, et cetera. So that's what a lot of this report is. We were tasked with looking at what existing data is available today to measure this care gap, and where are there gaps in the data, and how could we address that to, again, have a plan for measuring the care gap for all of these areas. So the next section is the federal reporting requirement. And all I'm going to say about that is it's the access rule, the federal access rule. It's a long rule. You probably know it better than I. But there is a provision in it that requires states to report for their home and community-based services on the percent of authorized hours that are provided within the past 12 months. That is, a much higher level type of measurement than actually looking at individuals and what they were authorized for and what they actually received. So it's a different measurement, but sort of within the same, I think, spirit, in that there is a desire to try and keep people at home if they can stay home. Well, I went through this myself with my mom. That is very difficult to do if you don't have resources. And I mean resources in a lot of different ways. So part 1 on the bottom of page 3 is all about the sections in the resolve that are covered under main care. Main care's policy, and if you look at table 1, which follows on the next page, it's a list of all of the sections of policy in main care that have some level of community and home and community-based services. And essentially, the bottom line is those services have both claims and, for the most part, an authorization that goes with the claim. And it's all in one system. And the system is called Gainwell, but it's all in that system. And today, Gainwell sends data to MHDO on all of main care's claims data. Just like all the commercial payers, that is one of our data streams, is all payer claims data. So we could essentially, with some changes to what Gainwell is sending to us, we would work with the department and create a supplemental file where they would include the authorization information so that we could link up the authorization in the claims and produce a report. So for the services that are provided through Maine Care, as described in this report under Part 1, there's a pretty bright line to it. We could do that. I mean, it's relatively, I mean, there would be some work involved. Whenever Maine Care has its vendor, just like me, do any kind of change, there's always a cost associated with that. But it is doable in that the information exists. We would just need to get it into a format where it comes to MHDO, we do the linkage, we could do the reporting. So if you move on to page 5, part 2 is all about the services that are covered under or through ODES. They're not under Maine Care, so there's not a claim and there's not an authorization. The way these services are structured is very different. They rely on a different process, different documentation. And here's sort of the big thing that I learned going through all of this. There's a lot of external players that are part of the process around getting people these services. So if you look at after page 6, it's not numbered, but it follows page 6. It's a flow chart. And this may be hard to see. I'm having trouble with these glasses, but in any event, the flow chart is really meant to give you a visual and some information about all of the different players that are involved in getting folks services under these different sections of policy. And the reason why this is important is because it's not like the issue with Gainwell, where they can just send us some authorization data, we link it up with the claims data. I make that sound easier than it is. I mean, there is, right, some work that has to go up, but that's relatively straightforward. With the second section, it's a little more complicated, and the data does not currently exist. The vendors that are contracted with the department, they've got information, but they keep it in a different way than the way we would need it to be able to measure what individuals are eligible. And they don't use the term authorized in this section, but what they are certified, I guess, to receive, right? And what they receive is tracked in a different way than the way it is with the authorization data and the claims data. Now, that's not to say that it would be impossible to create a structure for reporting. It just would require some work. The department would need to change its requirements with its vendors so that they would get this data from them. So not a bright line like there is with the first chunk of services we were looking at, but I think, there could be a path forward. So all of that is to say, and there's much more detail in this, but I know you got a lot of other things, so I'm moving quickly. I would just say that our conclusion again is anything is doable, right? The challenge is it takes time and money and the will. And what I'm saying to you is, and what's in our report, is the Maine Health Data Organization is fully prepared to take this on in partnership with the department, if that is a direction that you all and the department wants to move in. There would be some funding that would be required because this would be an additional responsibility that we would be taking on. I don't think it's a lot of money from our perspective. I'm not sure what it means for the department relative to changes that they would need to make. But from my perspective, one of the beautiful things about the investment that's been made in MHD over the decades is we've got this infrastructure already in place. So we would leverage a lot of that, but there is some new stuff, including the dashboard that I think, many want. Many want, it's not just about the data, but it's like turn that around into something so that I can understand what is going on. How many people north of Bangor have met services. And why is that? And the other thing I just want to say, if I have one more minute, is, and not to confuse you, but I do want to say this because, again, of the first preamble in the resolve, workforce is a huge issue, as you know, and you deal with. And that is a data stream that is currently not as comprehensive and accessible that it should be when you're having conversations about how are we going to sustain and grow our workforce, and in what areas do we need to focus on in terms of professions? And by the way, what areas of the state do we need to focus on, right? We don't really have that information. It's out there and sort of fragmented, right? We don't have it in a comprehensive database where we are reporting on that on a regular basis. And I am working with a group of folks who are very interested in this information. We are in the process right now of securing, if all goes as we hope, some external funding to help us pilot this concept and potentially make this something that is available to you all as policymakers and our colleagues and researchers and people that are working in our hospitals and all of the other healthcare, entities and this and that, to try and, be more clear about what is. And I've heard this over and over again, and I got to say it myself, we can't fix what we don't know. And that's what I think the role of the Maine Health Data Organization. We won't bring you any policy solutions, but we will certainly help you with data. And so I'll stop there. I'm happy to answer any questions. There's a lot. And I think you all have a bill that might be in front of you that had a placeholder for MHDO. Because in that bill, I think it was envisioning this work, but because you passed the resolve, we've already done the work. So again, our recommendation is in here, and I'll leave it at that.
Yes, go ahead. Looking through it. Yeah, sorry.
Any questions from the committee? Representative Graham.
Thank you, Madam Chair. Thank you, Carly. Nice to see you. We go way back. Am I correct in understanding that it's easier to a certain degree to understand the main care system, but because ODES is so complicated and it has very fragmented different pieces of data, that's harder because of the huge matrix of all the other components to ODES.
And so, yes, I would just say that I think the way they have structured is probably, the best way to structure it in terms of contracting with all of these external entities to help people in the community that are, trying to access these services. I think the challenge is when you want standardized data and that data lives in all these different systems, yes, it creates some challenges for sure.
Any further questions? Yes, Representative Shigori.
First, wow, that was that was very well done and very quickly. So for the main care data, you already can do what you described as sort of an idealish situation where we know what hours are missing in what regions and how many and all that. But for the ODES part again, you said that would take some money to do that. Would that be a one-time cost just to set it up? And then once everybody's uniform in their reporting standards and they're putting it all in, ongoing costs would be minimal? Is that?
That's right from MHDO's perspective.
Okay.
I think that's right. I mean, I don't think that, I think once we get things set up, and a lot of that work in setting it up is, I think it would fall on the department because of the relationships and contracts that they have with these external. So I don't want to speak on their behalf, but I think from MHDO's perspective, that's right.
Okay, and just a quick follow-up. So assuming they did that, you could generate this more or less analogous information that could be displayed in an apples to apples thing on a dashboard regionally based and all that.
That would be our goal is that's what we love to do is create dashboards. And if you look at MHGO's website, I mean, we got dashboards. I think the challenge is, right, making sure that the information that's in those dashboards is actionable and that's what people want. So, I mean, I have my ideas on what I think would be, useful information to put in those dashboards. And I think that would be, again, conversations with the department. We would be doing this, the way I see it is we'd be doing this on their behalf. And really, I think there's a lot of good things that we in this state have been fortunate to, because we've had such a commitment to data. There's lots that we're doing now, reporting geographically, whether it be by county or whether it be by zip code or whatever it is. And so I think we have some really good, what am I trying to say, models that we can look to.
Okay, thank you very much.
Any further questions? Seeing none, thank you for that very thorough reporting in such a short amount of time.
Well, thank
The
you.
ability to summarize it. Appreciate it. Our second report is coordination of services in Maine's E911 system and the 988 Mobile Crisis Services System, presented by Bria Maselli. Come on up and introduce yourself.
Hello, I'm Bria Maselli. I'm the Associate Director.
There you go.
There we go. Hello, I'm Bria Maselli. I'm the Associate Director of Adult Mental Health at Office of Behavioral Health and Crisis Services fall under my purview. So thank you all for the opportunity to present the great work that's been happening between Office of Behavioral Health and our public utility colleagues at Emergency Services. So it's my understanding you all have your report. I'll do a quick summary and here to answer any additional questions, and then also able to stay for the working session for 1216 as well, since it is related. So why this work really matters to us is in 2021, we were really working diligently with our access to our crisis continuum. Part of that continuum is to ensure that there is always a person to call, there's always a person to respond, and there's always a place to go, and making sure that those elements of our crisis continuum are really appropriate for the level of care, diverting away from high cost, high utilization services, and making sure people are accessing the care at the right level from the right person at the right time. And so in 2021, we started working diligently with building our capacity for the federal mandate for each state to be receiving national 988 calls. And also part of that was a resolve to start also working with our Public Utilities Commission on what does this mean for 911 and call integration. And so we have done a tremendous amount of work over the years. You'll see a timeline of that work within the report, as well as links to see each of those iterations and milestones that we've made along the way. So here in Maine, we know folks in crisis have an opportunity to call 911 and receive a response when they are having a behavioral health crisis, and they have the opportunity to choose to call the Maine Crisis Line, which serves as our 988 call center for the state of Maine. Two systems serve very, very different purposes. Obviously, our 911 is really that public safety, emergency, and medical response, where our 988 is really a behavioral health social work response. And so it's really important to help folks understand when to call which line. And we understand that folks may call the whatever line at that moment feels right in that moment. And through a conversation with a call dispatcher or a crisis line, there may be a need for call transferring between those two lines. Without coordination, we do see that law enforcement might be responding to a behavioral health call, which might actually escalate an individual experience a behavioral health call. And then we also may see on the flip side that individuals might be receiving a behavioral health call and then needing kind of law enforcement to get in depending on the scene. So we've been working diligently through the legislation from 2021 to really bridge and understand how best to align those two call options for Mainers. What we have done was we've created uniform protocols, spent a lot of time understanding each system's language and approach to the work. really aligning that work for something that we really feel strongly in an understanding of shared common language. And then we were able to establish uniformed protocols. So the protocols that we've built are a behavioral health call receipt protocol, a transfer protocol, and an assessment protocol. What these protocols do is they allow the PSAP or dispatch only centers to ensure during that call time that they're able to screen and assess that this is a behavioral health call and how appropriately to transfer that call to the 988 main crisis line call center. They can do that through call transferring. So if any of you have called poison control or others, you may have your 911 dispatcher on and another person joining you in that conversation. They have the ability to do that. So even if we need a emergency response, there's a social worker on the phone supporting the individual in that time. So they can do kind of that ability to join a call and coach and support on a call, and they can do a direct transfer where that call officially goes from one center to the other. And this behavioral health protocol helps the call takers really establish what is most appropriate and who is best for that response. So we also have done significant amount of training with our PSAPs and dispatch centers. We have trained 303 staff in the policy, the behavioral health policy. We have trained 484 emergency and medical dispatch in Protocol 41, which is the caller in crisis protocols, and that is specific to mental health dispatch. Since 2023 and 2025, where we were slowly rolling out protocols and testing protocols, we have been able to successfully transfer from 911 209 calls to the main crisis line. 156 were resolved by 911 call specialists without needing emergency response services to go out. 53 did need additional supports in person, but they only elevated to the need of needing a behavioral health worker on scene. And 33 stayed on the line with 911 and 988 while we worked on a response that was most appropriate for that individual. So we've had great success. These successes really help show that the protocols we've built are working in the way that we want them to work. It is building trust to show that the right response is out there, and we just need to coordinate individuals in Maine to that right response. So with all of this good work happening, there are still challenges. We can still see more calls being transferred. There are consistent workforce shortages across the state. So again, we're monitoring our call lines, making sure that we have enough call takers, enough call responders, and building capacity within those mobile response through other initiatives that we're currently working on. We are working on data sharing and ensuring ways to capture and monitor the calls that are transferred and the outcomes of those calls so that we're able to utilize that as we're building relationships and trusts with our 911 dispatch workers and PSAP centers, as well as the community to know the process and systems working. There have been some challenges with adoption from some of the call centers, and that really does look more at like HIPAA and challenges with sharing information from the call centers to our 988 centers. And so within the report, you'll see some policy and legislative recommendations. One really focuses on the Office of Behavioral Health's need to really codify what is 988. It's a national program we're mandated to do, but within our policy and legislation, it's really not rooted into a service and well-defined. And so I think that's the work we're really looking of LD 1216 to really help us codify that language so that we know what it is. We know that it is part of the already identified call response that we're to have. And then there's also some recommended public utilities commissions policy language related to reducing barriers around confidentiality to improve some of the call transfer protocols.
I have a question for you. May I ask it?
Certainly.
You mentioned 1216, which is coming up
Yes.
this afternoon. So this bill sort of helps address your challenges?
Yes, it does.
Just good to know.
Yes, it
Thank
does.
you.
It absolutely does. It really does help codify that language. It helps really show that we are taking the federal mandates. It helps us with securing the federal funding that we are implementing that federal directive in a very strong way. So yes, it would.
Thank you.
Happy to take any other questions related to the report.
Yes, go ahead.
Thank you, Mr. Chair. Thank you very much. Curious, but you mentioned HIPAA.
Yes.
My understanding is that HIPAA has the exception for emergencies. Aren't all these
Yes.
calls by definition emergencies?
Yes, there is language, and I think that that is definitely something we're working through. And as you can see in the recommendation, in the policy language, it reinforces that so that it
To
will
make sure people understand that.
understand it and understand appropriate use of that to help minimize kind of what folks might be using as a current barrier.
I'm really glad to hear that because I see that a lot.
Absolutely.
People are so cautious that's a barrier to people getting
Absolutely.
emergency or other care that's needed.
And it
Thank you.
really, as you mentioned, has a different approach when you're looking at emergency services and crisis services in regards to what can and cannot be disclosed. So,
Appreciate it.
yes.
Further questions? Seeing none, thanks so much for the
Great. You guys
report.
made this easy. Thank you
Appreciate
so
it.
much.
And we'll get prepared for 4 work sessions coming up.
I need to see can.
Oh, take the time. This is an opportunity to take a 5-minute break.
Back in the right time.
Oh, I'm so glad. You're here. You missed a lot. I'm telling you. No, I'm just
I
kidding.
did.
I'm just kidding. Everybody's back, it looks like. We'll be working on LD 1216 first, and then I'll call the order of the bills after that. You can call a caucus anytime you.
I know. I keep forgetting, it's the money.
Yeah.
It's the money.
Okay. Okay, just about ready to start. For folks that are in the room, we're going to work the bills in this order today. We will start with LD 1216. And then we will go to LD 1414. LD 1955. And then LD 1728. And finally, LD 2066. And thank you, Anna Brome, for being here today.
Okay, so I'm basically just going to tell you what's in front of you, and then I'm going to turn it over. So what you are looking at, the pink sheet, is the same as what is in the report that you just had. But there's a couple of things I want to say about it. So first of all, I wanted to draw your attention. If you look on the pink sheet, you can see in section 2, you can see the whole section that they are proposing to amend, as opposed to the subsection, which is what you can see in the report. And the reason I want to draw your attention to this is because this law is from 1987.
Oh my gosh.
And if you look at the lead-in, there's only 4 counties in here. And my understanding, after going back and forth with the department, is that they do cover all of the state now. Now, I'm not the experts on these, but Bree would be prepared to sort of explain to you, what they do and how this sort of fits in. And it may be worth updating this while you're at it. And if you want to do that, I can work with the department to do that if you want to move forward in that direction. It doesn't change, I don't believe, the spirit of what Senator Nangle is looking for. It doesn't change that section 1 at all. So if you want to hear from Bree about that and you want to see how the sponsor feels about it, I'm just going to leave it at that. But this is very old law, and you can see, that there's only 4 counties in here, none of which actually is in Senator Nangle's district. So just see where you want to go with that.
So Bree, come up
Yeah, come on up, Bree.
and you want to introduce yourself.
Hi, everyone. I'm Tim Nangle. I'm Senator Tim Nangle. I represent Senate District 26, and I am the sponsor of this bill.
And I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County and 16 communities in eastern Hancock County as well.
Go ahead.
As mentioned, this is outdated from 1987. We have for many years.
Could you just introduce yourself
Oh,
again?
yes,
I know
I'm
you were
sorry.
just up, but yeah.
Bree Maselli, Associate Director of Adult Mental Health at Office of Behavioral Health and Crisis Services fall under my purview. So yes, this is old crisis language from quite some time ago. We have been operating a statewide crisis and mobile crisis response program that is statewide. We do identify through procurement protocols a provider in each one of the public health districts, and they are responsible for covering all mobile in-person encounters within that district. And they also have contractual relationships with Office of Behavioral Health to serve anyone in regards to payer source. So we do support that work, and it is available fully statewide in all 16 counties.
Yes, go ahead.
So thank you, Bree. So you would say we probably should add the other counties if we're going to have them specified into the.
We're doing the work, so I don't see challenges with that.
And I think she thinks it's a little more complicated than just changing this to all the counties. There might be some other changes as well to update from what they did in 1987 to what they're doing now.
Just to modernize it just
But that would come
slightly.
back on- That would come
be
back
nice.
on language review. That would come back on language review.
Yes,
whatever it
absolutely.
took.
Yeah. And who can name all 16 counties in this committee right now? Just kidding.
It's a song.
I bet you.
I know, right?
Rep. Zager.
I bet Zager
Are
could.
you going to name the committee?
I'm not going to name the counties.
You have to sing it.
My daughters could do that, but we'll have to bring them in some other time. I question on that is in the tribes, are they considered parts of the counties for service purposes and also for the language for the bill?
Yes, so they share in those counties. We do have strong partnerships. They also have their own kind of version of their tribal call line, which is very similar to our 988 call line that also has protocols for transfer. They do support and collaborate with the mobile provider, as well as offer some of their own crisis continuum support services
And they're integrated.
as best
Yeah.
as we can right now.
Thank you.
But
Any
yes.
further questions? Represent our Senator Nangle.
Thanks. Thank you for being here. What other? Well, first, in 1987, weren't they still using leeches?
Maybe not for mental health.
Right. What other changes do you think would be necessary in this?
Well, I think what is currently in there, as we are focusing in on codifying, really the element of 988 was really what is most important in regards to how we continue to sustain and grow the current call center and the 988 work to meet our federal mandates. And so the purpose of that was really honing in, codifying that, and really getting that well-defined. And so I think it's great to have that identified and very clearly noted. I think some of the other things within the current, again, the counties, we do a mobile crisis response. We're going through crisis reform work right now with Office of Main Care Services. So our model is shifting to a co-response model versus a one-person model. It has some really great innovative best practice qualities. And so how we describe what we know today as mobile crisis is slightly outdated. So updating some language that way.
Would it be easier just to remove the counties and just say the state of Maine?
That would work.
I just assume you're willing to work
Absolutely.
with Anna and get this
Absolutely.
all squared away.
Yes, absolutely.
Thank you.
Any further questions or comments on this? If not, I will entertain a motion. Did you want something to say?
You got to turn. yours
Representative
off.
Loveland.
Slide it. There you go.
No, I was just going to make a motion.
Okay, go ahead. We have a motion.
It's your bill. You
I
can-
make a motion not to pass.
Ought to pass?
As
amended.
as
Do
amended.
we have a second?
Yes, second.
Second by Rep Meyer.
And just to clarify, this is working with the department to clarify, okay, I'm just making sure it's not just what's on the pink sheet.
Yes. All those in favor? Great.
We'll be in touch. Thanks.
Thank you. Next up
Alrighty.
is LD 1414.
Thank you, everyone.
Thank you.
Welcome. Good luck over there.
Yeah.
Doing the school bus on.
Oh.
Are you happy?
This could have taken a little longer, so I don't.
You can stay. LD 1414.
The look on his face was like.
We need to train.
All right, LD 1414. So this bill was originally a concept draft to update the support and sustain the state's child care workforce. There were a couple of iterations of this. We won't go into the weeds of the joint rule, but the way it was originally posted online had a different beginning section around the salary supplements, which I will skip over. And then the second part of what was posted online, which has remained the same. The amendment requires the Department of Health and Human Services to establish a grant program to facilitate the availability of childcare between the hours of 6 p.m. and 6 a.m., in other words, sort of non-traditional hours. The department must establish the grant program so that directors or owners of childcare centres or family childcare providers may begin applying no later than January 1st, 2027 for funding awards for use in the fiscal year of 2027-2028. The grants are for childcare providers to hire experts or consultants or dedicated staff to develop a plan for how a provider could or would provide childcare services for any portion of those hours. And the grant would be up to $10,000 on a one-time basis for an applicant, and that's because it is solely for the purpose of consulting and figuring out whether it's possible. The department would develop the grant program, including the criteria and process for applications, awards, oversights, and any other relevant requirements. And then there is language in here that says, provided that sufficient funding has been appropriated for the purpose, the total amount of grants awarded in the fiscal year of 2027, 2028 is up to a total of 500,000. But if the fund is extended before the end of the year, no more awards are granted. And the reason it's worded that way is because the sponsor is aware that it takes time to develop a program, and because of the way the fiscal note process works, that amount of money is outside of the biennium, so it would be in the future. And if this were to be enacted without the funding piece in the future, then they wouldn't be able to move forward. So that language is the sort of stopgap for if that were to happen.
So it's kind of if language.
Well, yes, it's so the department don't find themselves in a position of having to implement a program for which funding wasn't
Okay.
appropriated, because that's funding that you would have to appropriate in a future budget. So there's no sort of no way around that.
Okay.
And so they understand that, and that's why that language is there. But prior to the public hearing, the sponsor requested a supplement, the supplement section be replaced with a requirement that the CCAP reimbursement rates for providers taking care of infants and toddlers receive a 20% increase in the reimbursement rate rather than the current 10%. That was sent out in an email because it's a long story why it can't be drafted, but it doesn't matter. So during the public hearing, you heard from the proponents about infant and toddler slots being the scarcest statewide with significant wait lists. The CCAP doesn't cover the cost of care. The market-based reimbursement doesn't reflect the staffing realities of higher ratios, facility costs and quality requirements for infants and toddlers. Providers either don't offer it or they are offset by the revenue from sort of older children that are in the same childcare facility. You heard about the economic impacts of this on the workforce, on the business decisions of providers, the poor pay for child educators and employees, making it difficult to recruit and retain staff. These are things, there's a theme to these bills. And there's a lack of options outside of traditional hours, particularly for, childcare needs for people in the hospitality industry, the medical field, things like that. And you also heard about testimony about liability insurance costs tripling or being dropped altogether, and whether the overnight might make that an even worse problem. And the department, their testimony came in on the original concept draft. So federal funds for childcare are being fully expended. An increase in salary supplements would require general fund, and favouring one group of educators over another would likely have consequences. Part of that is still true here. With the change is the issue of the childcare block grant. And they also said there was a lack of clarity regarding the grants as to what happens if the providers decide that they can't do that. Is there any kind of consequence for that? So we did ask around the issue of whether there's sufficient funding in the block grant for additional increases in the CCAP to provide infant and toddler care, what it would mean for wait lists. I wasn't sure about what's allowed under the federal rules around those differentials, but the department have said that the state could have a higher differential. They could go from 10% to 20% if the state wanted to, and that would be supported by market data. They could easily support that. They're permitted to do it. It would cost about 1.56 million. So technically they could do it, but there isn't additional fund in the block grant. And so they would need general fund to do that. Otherwise, it would reduce spending elsewhere. This is the way they put it, in ways that the department is opposed to. So just as a reminder too, this is a program that under federal law is the 85% of SMI. The state does 125. So that sort of plays into some of the general fund costs of this too. But that's the sort of the extent of what I know. But there are lots of childcare people. I was very happy to see Bobby and Tara and Heather all in the room, as well as the sponsor.
Any questions around this? Any questions needing for clarity? Some of the experts in the room. No? You ready? I'll
Are
entertain
you
a mo-
entertaining a motion?
Yes, I am.
I would move ought to pass as amended on LD 1414.
Get a second on that? Second. We have a motion on the floor, ought to pass as amended on LD 1414. All those in favor? And are you just opposed?
Ought not to pass.
Ought not to pass.
They need to put their hands up. We need to count them in.
What's that? Oh, you want?
Put their hands up. We need to put our
Oh,
hands
yeah.
up.
Go ahead.
Opposed.
Show of hands opposed.
I'm sorry. Where are you?
Yeah.
This was.
The motion was ought to pass as amended
And who's opposed to it?
and opposed.
Opposed. Put your hand up. 1, 2, 3.
And then Abby.
4.
And then Abby. Okay,
And just to clarify, that is the pink sheet, right? That you
Yep.
were looking at, plus whatever the fiscal note is.
Yes.
great. And LD 1955 is next.
Okay, so this is another one in which you should have a pink sheet in your folder. This is a bill that came back was recalled from the governor's desk and then sent back to committee. So you've already had public hearings and work sessions, so there is no blue sheets from this. There is just a pink sheet. And this pink sheet is some pieces from the original 1955 and the amendment. So I will just let you know which bits are which. So the amended, this section, I believe, was from the amendment. This is the non-lapsing fund. This is just the technical language of the CCAP funding not lapsing. And then the section, this is again from the amendment. This is section 6 of the amendment, just marked up. This is the department shall develop a long-term plan that ensures financial sustainability of the CCAP program. The plan must include the necessary level of funding that must be appropriated in order to serve all families that qualify for the CCAP. The department shall submit a report with a long-term plan to this committee. This is updating that to December 15th of 2026 and giving the committee authorization to report out legislation. I do also want to point out that you did receive a report which is related but not the same on the CCAP funding. And that was, so I can't find it right now.
This one?
Yes, but I wanted to let you know what the statutory section is from. Well, I'm not going to be able to find it right this very minute.
Right here.
And then the last section, which is different from what you had before, this is a $15 million funding in the second year of the biennium for the childcare affordability program. This is drafted as one-time funding. And I forgot what I was going to say. Anyway, that is the one section that is different from what you had before.
Okay.
Oh, because there is a long wait list. That's what I was going to say.
And I understand, I want to make sure this matches up, this amendment matches up with any suggested amendment on the part of the sponsor. So for that, I'd like to call the sponsor forward.
Thank you. And
Welcome.
hopefully, I doubt I can ever be as elegant or as well put together as Anna, so I'll try.
Could you introduce yourself?
Good afternoon, Senator Ingerson, Representative Meyer, and esteemed members of the Joint Standing Committee on Health and Human Services. I'm Maddie Daughtry, and I get to serve as the President of the Maine Senate. And thank you all for taking your time with this bill. I know it is a little bit like Groundhog Day for having it before you all. So, as you heard, there are some changes and some concerns that led to it being pulled back from the governor's desk. So we all know CCAP is an incredible program, ensuring that our students are getting high quality early childhood education, benefiting our providers as well, giving them stability in attendance and the ability to serve lower income kids. But we know about the wait list. I know that you have other bills in front of you all that are dealing with the wait list as well. But the Right from the Start Coalition has requested that the bill before you be amended for the very key part of providing ongoing funding instead of one-time funding. And I do support this amendment if the committee does choose to add it to the bill. I think the big concern that we heard loud and clear, and I think this is not just this, I think it's throughout state government, when we have a great idea and providers and folks are able to take advantage of it, parents are seeing how well it can work for them. If we do not provide a stable and sustainable funding mechanism for it and just do one-time funding, it sets it up for failure for future legislatures. So ensuring this is something that we're talking about is ongoing, that families and providers are able to count on in the future, I think that is really key.
So just for clarity, would it mean 15 million a year or would it hold the balance at 15 as we go? If there's any leftover funds they would carry and then it would.
I would be amenable to either,
Okay.
but I do recognize the difficult budget environment that we're in. I think the biggest thing I would like to see is have the department have the flexibility to be able to carry over funds and be able to be dynamic and responsive with the funding that the legislature is able to allocate to them at that time.
And that's the
So-
non-lapsing.
Yes, and the non-lapsing.
That's what?
That's the language on the
Yeah.
pink sheet.
Okay.
Because that was one of the really
Good
big
to know.
concerns that I had as well is before 1955 got pulled back, I had the concerns and it was wisely flagged for us that it could, without the non-lapsing, it could also jeopardize other portions of the program before the amendment that's before you.
Okay. Okay, good. Are there any further questions? Yes, Senator Moore.
Thank you for being here, Madam
Of course.
President. I guess out of curiosity,
Yeah.
what was the governor's, I don't want to say rejection, what was her concerns and why it was returned to us?
Literally the amendment that's before you and the concerns of the drafting, it was literally an error that we found that, it wasn't an opposition from the governor. It was,
Okay.
we need to get this bill back to this committee to get corrected.
Okay. And so that correction then, because the pink, are we looking at the pink? I guess that's what I'm asking. Annie.
Yes.
And I
It's saying
apologize,
the
I do not have
initiative
pink
provides
slips.
one-time funding.
So the request from the Right from the Start Coalition is in addition to
Oh,
the
in
other
addition to-
changes of the amendment.
Gotcha.
Is to change it, sorry if that was confusing, from just the one time to
To
ongoing.
ongoing.
Yeah,
Okay.
so they're, one's the correction and the other portion is in light of the ongoing work and from hearing from the advocates who are here behind me, they've made it very clear that ongoing would be better than one time. So,
Thank you.
yes.
And I guess go ahead. You go.
Thank you, Mr. Chair. Thank you, Senate President. Do you have a sense of how this appropriation would affect the wait list, that 1,000 kids that are on it?
Certainly call someone else.
Yeah, I was gonna
If
say,
you want some help on that.
I have my hunch, but I also do not want to speak for the folks who do this every day. So I think that's a question that is better reserved to the department, not to look over my shoulder in that direction.
All right.
But I think I said this in my testimony on both bills. The number one thing we need to do is clear the wait list, but we also need to recognize that that alone is not going to solve this issue. And so that's why both the bill before and this bill and with its changes are hoping to take that broad-based support. So.
Any further questions for Senate President Daughtry? Oh, I'm going to, if you would mind coming forward, Director Johnson. Might be helpful to answer Representative McCabe's question.
Good afternoon. I'm Bobby Johnson. I'm the Director of the Office of Child and Family Services within the Department of Health and Human Services. And to Representative McCabe's question, the analysis that we did is that to clear the families that are currently on the wait list would require between $8 and $10 million. And that doesn't include any additional applications that we would get.
Any further questions?
She does.
Oh, go ahead, Representative McCabe.
That is welcome news. I just want to put forward to the committee, in light of the fact that there are, I think, around 10% of eligible families receiving the Child Care Employment Award. I wonder what the appetite is to add childcare workers to the list of prioritized families for the CCAP award, because so many aren't receiving the employment award. That was kind of a mouthful. But currently, families experiencing homelessness and children with disabilities and families earning under 30% are prioritized for CCAP. And I want to add to that list childcare teachers who are not receiving the employment award, because 90% of folks are not. Just gonna throw that out there.
Any questions on it? Yes, Senator Moore.
And I don't know that this is necessarily a question, but I guess I get really concerned about the wait list. I mean, we all are. But prior to increasing, because I remember we did that several years ago where we increased the family income to be, it was 85%, which is what the federal government allows us to do. And we increased that to 125%. We really didn't have a wait list prior to doing that, did we?
We did not.
That's what I thought. So it, unfortunately, we we created a monster because we did provide subsidies to families that needed it. But prior to that, we were okay at 85%, and we had been at 85% for a while. So I guess I'm just, that's a concern. So, thank you.
And I would say the majority of families that we're serving currently are in the 0 to 85%. And then we have a smaller number of families that are the 85 to 125%.
But unfortunately, that depleted the funding that we were getting from the federal government with that small amount in there between the 85 and the 125. So we're not able to provide services to some of the 85% ones because we're out of funds in the other one. That's what my experience with my constituents. And the number keeps growing. So,
yes, we have been working diligently to ensure that the amount of funding from the Child Care Development Fund is within the percentages that are required by the federal government. We continue to look at moving families, children off the wait list as we're able to within the resources and the appropriations that we have.
Thank you, Bobby.
Any further questions? Seeing none.
Thank you.
I do have a question. I'm not sure who it's for, though. I think I'd like to call up Heather Martin.
Hello.
Hi.
Good to see you all. I'm Heather Barden. I'm the co-executive director for the Maine Association for the Education of Young Children.
Okay. I'm just thinking about what Representative McCabe said about adding childcare workers as a priority group of people for the CCAP. Is that correct? And I know we have a separate bill to continue the pilot program. Can you talk about how adding that would be helpful to this bill, or whether we should, what we should do, but just your thoughts on what the landscape is right now?
Yeah, I think obviously it's a great workforce initiative combined with what is intended in LD 2066 to say, without the workforce, we don't serve children. So I would be supportive of it. I think it's a good measure to recruit and sustain the workforce. Appreciate it. Looks like you've read the report, which did show we're only serving about 10% of those educators who have children in that age bracket that could receive some support. So I would feel personally supportive of it. Yes.
Curious about that.
Yeah.
There's a lot of ins and outs to childcare supplement awards.
Yeah. Could I add something to Senator Moore's question?
Absolutely.
Is that okay? Yeah, so I just want to make clear that, the up to 85% of families, we can only use that federal money on. We can only use federal money on them. And then the additional, which is about a 10 million to cover that 85 to 125%, that can be used through the whole gamut. It didn't stop at just that population of people. I also want to point out the great work you've all done to helps subsidy become a better program, a more accessible program. You've passed a lot of statutory language in this committee to actually make sure people can access subsidy easier, make sure that programs can work in the system easier. So I think there's also some correlation there about the wait list, is that more programs are able to accept it now and work within it. I think what we're going to talk about at LD 1728 and the payment practices are a reason for that too. So I think there's multiple things at play on a wait list here. I would say a lot of us advocates of Right from the Start Coalition, many years ago, this program wasn't publicized. You had people eligible all over the state who had no clue this program existed. I think the department and pushes from you all in this committee too, in collaboration with the department, has actually accelerated the marketing of this program and the ability of people to work within this program too. Thank you.
Thank you. Any further questions? Seeing none. Okay.
So the vehicle for that would be the other bill? Yeah, because you have another bill for the 20.
I think the vehicle sounded like
Heather, would you mind just? You're very sparkly today, too.
Thank you. I think we all needed a little sparkle, don't we?
Your comments about Representative McCabe's
Yeah.
suggestion, the vehicle for that 2066, probably the more likely vehicle for that. Makes more
Yeah, I
sense.
mean, I would trust policymakers and maybe Anna's
Yeah.
insight on that. I think it could be an either.
Yeah.
Okay.
You could say as part of CCAP and, hopefully passing a bill to invest
Yeah.
$15 million, part of that would also be an amendment to put a
Yep.
new priority group in.
Yep.
Or you could say through 2066,
Yep.
we would add this program as a priority group within. So I would trust you all in your judgment.
Yeah, thank you.
Yeah.
Rather do what?
2066, yeah. Thanks.
Good, thanks.
Yeah. Mm-hmm. Anything else to add on this one, 1955, Anna? Okay. Any further questions from the committee?
No.
I would entertain a motion. Representative Zager?
Thank you, Madam Chair. I move all the passes amended on 1955.
I think the motion and a second from Representative Graham.
And this is the pink sheet plus ongoing, correct?
A pink sheet plus ongoing. All in favor? Annie? Okay. Those opposed? And the minority report?
That pass.
Right. Next up is 1728. I'll let Chair Meyer take over on these since they're my bills.
All right, so 1728 is another one you should have a pink sheet in. This is a carryover bill that was a different aspect of childcare in the first session. I guess I'll just go through what it does. So the first section is it's putting in statute some things that are currently required in rule or we're going to be required in rule at the federal level. So, and I'm not the expert here, but I've got a decent working knowledge of it. So the first section of the bill is putting in statute the requirement that a copay can't be more than 7% of a family's household income. That is the current federal rule, but there is some proposal to, there is a rulemaking going on at the federal level right now, and there's a proposal to remove that as a requirement of states, which doesn't mean states can't do it, but that they would not be required to limit the copayment to 7%. And so if I say something wrong, I want one of the people behind me to wave their hand at you and go, no, she doesn't know what she's talking about. So that's the first piece. Then the second piece, and I know there's some conversation around what you would like to do here, Senator, is co-payments may be further reduced or waived by the department. Right now, that is includes families earning no more than 30% of the state median income, foster care, families experiencing homelessness, and families with a child with a disability. I'm just going to go through this as I'm looking at it at the moment. I do know there is a proposal to change that. And then if you remember, last year you had LD 561, which was the bill around childcare providers that were receiving subsidy being paid on enrollment rather than attendance. And that bill was amended by this committee and currently is on the table. And that, if you remember also, was another thing that the federal government was changing in the rules, was to require the payment based on enrollment rather than attendance. And that is another piece that is currently being proposed to be changed in the federal rule. So this is not the amendment that you sent to the floor. This is the closer to the original bill, and there are some reasons for that. So there's a couple of other things in here as well around, I forgot, the second part is just is related to the co-payments, and that's just basically posting it online. So that's really just a piece that goes along with the first piece. So I'm talking about section 3. And there are some other parts in here around things like the goal of ensuring that high quality childcare providers will participate in the subsidy program and make a plan to align requirements for providers accepting the development, the assistance with the practice of private paying childcare providers. The prospective payment is in there that was removed last year. The holidays and vacations, and then there may be another couple of things I can't remember. I do just want to draw your attention to the piece that is crossed out in there. So it says including enrollment based rather than attendance based practice, and may not be reduced or eliminated based on the child's attendance. There is a reason why that's been removed. Can't remember it exactly, but the folks behind me know why that is, and that has been asked to be removed by both the department and by Heather for reasons that I can't quite remember. But so that's the reason I put that in there is because I wanted you to see that most of this is the original 561, but those few words would need to be removed. And then the last part is around reimbursing a provider for childcare services for subsidy payments that are over the market rate when the cost of care is higher for a similar kind of family that isn't receiving the subsidies. But I'm sort of at the limit of my knowledge here, but there are lots of experts in the room. This language has been run around the block a few times. Yeah. So everybody sort of behind me understands this much better than I do. So the only thing is I don't want to forget the part around paragraph B, but I will leave that to Senator Ingwersen since this is his amendment.
This is anything that part that I had a problem with. I wondered if that language got changed to may, if they're okay with it.
Okay,
Call them.
sure. Does somebody from the department want to come up, either Bobby or Tara?
Good afternoon.
Hello again. Thank you for being here.
I'm going to introduce myself again.
Yeah, go ahead.
I'm Bobby Johnson. I'm the director of the Office of Child and Family Services within the Department of Health and Human Services.
Thank you. We're grateful you're here. Do you have a question you'd like to ask the?
I
Yeah,
do.
Go
I know
ahead.
we've been working somewhat with you and also with other stakeholders on this. And one of the things that seems to be around the co-payments. And I'm wondering if the may language would sort of satisfy, given, because may would mean given that there's available funds. And I do want to kind of avoid any unnecessary fiscal note on this bill. So just want to hear your thoughts on that or what you would suggest possibly.
Yeah, I think that would be better. The current language in the bill doesn't align with current rules or practice as outlined, and it would require a fiscal note to build the changes into Baxter, as well as result in an increased spending in the Child Care Affordability Program funds, which could add to additional children going on the wait list as it's currently written. If we add these other categories across the board as ones that would be eligible.
So what, you have some suggestions of what you think should be changed?
So families with income up to 30% of the state median income is, we currently do that. Children in foster care, families experiencing homelessness, and families with a child with a disability are the ones that we don't waive the co-payments as a policy for all of those families in those categories.
So that would cause a fiscal note.
Correct. So that,
So even if the language says co-payments may be reduced or waived, it doesn't really change things for you. Right at B where it says they may be further reduced.
I mean, it certainly leaves that at the discretion of the department.
Yeah.
With that language, yes.
I'm just wondering, committee, if there's a way to leave this language in, but not
require it.
Not require it. Said may sufficient or given available funds or something like that. Okay. Thank you so much. And the rest of the language looks okay?
Yes.
Okay, great. Do we have any further questions or comments? Yes, Representative Lemelin.
Thank you, Senator. How much are co-pays now?
They vary. Let me just look. So a copay limit of 7% of family income is already part of both state and federal rules and built into our Baxter system. And I think they go up. I think Tara would probably know better. Up to 10%.
The state.
So up to 10% for the state funded, which is the 85 to 125 population of families.
What services require a copay? They don't all require a copay.
I'm sorry, I don't know if I understand your question, Representative.
When is a copay needed? A copay isn't straight across the board, correct? No matter what service you have?
This is CCAP.
CCAP only.
Yes,
Okay,
correct.
thank you.
This is
So
in the CCAP.
in CCAP, right now it's 10%.
It's up to 10%.
Up to 10%.
Correct.
Ah,
So
now I
some
understand.
families don't have a copay.
Yep.
Up to 10%.
Okay, thank you.
You're welcome.
Okay. And just to further that a little bit, that's based on income. Okay, thank you.
So just to be clear, the intent of this is to put what's currently happening into the statute. Under the
What's
current,
federal into
and-
state statute?
right.
Right.
That's my understanding, with the exception of this part around paragraph B, which is intended to be, that's what the may is for in that paragraph B. But my understanding, and please tell me if I'm wrong, is that this paragraph A, although, wait, so this would be, yeah, this is limiting the 7% to the 85%, which is what the current federal and state law is now. It's just not written into statute.
And that's
That
what they're
makes
doing
sense.
right now.
Yeah.
The 7% is not in statute? I mean, is there 10% in statute?
No, it's in rule, right?
It's in rule.
It's in rule. And you want to put in statute that it's 7% and include these other variables
Categories.
without incurring a fiscal note, sorry. Is that correct? Okay.
That's okay. I'm just making sure that you know that that question is over here, not here. Yeah.
Correct.
That's all.
It seemed like that was understood.
Yes.
Thank you. Be quiet.
Sure.
Yeah,
Hello again.
thank you. Good to see you.
You too.
You're kind of the expert on this also. And the intent behind this?
Yeah, so what we've seen in this program over the years, it's been a pretty steady program, and the fact that Maine does administer it, works with the federal government, and adheres to federal rules. But what we've seen is administration changes at the federal level, administration changes at the state level. This program can fluctuate pretty significantly sometimes. And when that happens and we change things like payment practices, we change things like co-payment rates on families, because there is some flexibility in federal rules. It creates an uncertainty and an unsustainability for childcare programs and families accessing the program. So we feel it is best practice to secure what is viewed as positive payment practices for programs, which mean it aligns with what private pay families are doing, and allows that stability, at least in some statute and protection in state statute. We know statutes can change at any time, but at least there'll have to be a legislative process to do that. And the public will get to plead their case and work with legislators on that. So we feel it's good to sustain this in law, so that way programs can at least have some confidence that their practices aren't going to change next year. And as they're budgeting, their models are going to have to change. And what you will have learned along with us is that the childcare business and the market is very fragile. So having some security in state statutes really important. And I think just to make sure folks understand the piece about the childcare market rate being paid, even when they charge a lower private payment rate. I'll give an example from a provider in Skowhegan. For many years, a home family childcare provider. She is trying to make sure her families can afford it. She has always charged them below the market rate, even though she is not paying herself a lot of money, even though she's not giving herself time off or benefits. But she has tried to make it work for her families socioeconomically in Skowhegan. And she takes children on subsidy. Traditionally, in the past, even though subsidy is a higher rate in her community, she used to get only what she charged private pay families. So she was actually taking a cut to accept children on subsidy, where Maine is paying, a lot of other programs in the state because maybe their payment rates are higher. So this is something that was put into practice last year and is helping programs also keep the cost down for private pay families. Because now they're not trying to set with the state, so they, in some times when they can maybe charge a little extra or work with families in a different way, they have the flexibility to do that. So I think that's another important one that providers are really appreciative of right now, that they're not getting punished for trying to work with the private pay sector too.
And Heather explained all that to me and it felt right.
I am so impressed by her for all the issue areas you cover, and I know it's complicated, but again, I think it just gets to what is good practice for childcare businesses and families, and what can we create that's consistent. So again, as different thoughts about this program change over time, at least the payment practices can have some stability.
Any other questions?
And that's subsection 8 on the page 2. That's what she's talking about.
Yep.
Right down.
A.
The bottom.
8, yeah.
Yeah.
8.
That's the part that
Right.
she's talking about that I couldn't remember.
Senator.
So my question, and I'm not even sure, Heather, this is for you or
Gotcha.
Anna, or I'm not even sure who it's for. So we've been saying that there should not be any fiscal note on
Yeah.
this one. And especially because we said may, if they want to reduce it or whatever. Why is LD 561 sitting on the appropriations table? What else did that include? I don't
I'll
remember.
tell you, that was really confusing to me last year, and I think it's with this must language. that is trying to be changed in this, because the must language added that population that they're
Okay.
currently not serving.
Okay.
And so I think a fiscal note got put into it, so therefore it got held up in appropriation saying, well, the money's not there right now. Are we really trying to pass this bill?
Okay.
So I think with a correction there of the May language, and if that was confirmed by the department, then there doesn't have to be a fiscal note. It means that's now at their discretion. If
they
money
have the
does
money,
come in,
yeah.
then they could extend their eligibility in that 0%
Cover
copay.
these folks.
Yeah.
That's
Yeah.
what just didn't make sense.
Yeah,
was
I
like,
think
why
that's
is
the
that
only thing
sitting
because I
there?
remember last year I talked with the senator about it sponsoring that bill and I couldn't understand. I was like, why is there a fiscal note? They're already doing enrollment versus attendance and then going through this must language.
85 to 125, I believe.
Oh, and that, I think it
That's what
allowed
it
that to be
is.
covered. And right now, the 85 to
Doesn't,
125
it's
is
just
a
up to the 85.
10%.
Yeah.
Still the 10% copay because that's a state funded portion, not
Yeah.
the federal. And federal, yeah.
Well, and I definitely support, paying on the enrollment instead of attendance. I mean, that makes so much more
That's
sense.
been I think that's been a real game changer for programs. And again, opening up more programs, that possibility to want to work in this program and help more children.
Right.
In
Well, it
this
makes
space.
more sense.
Yeah,
You've
yeah.
got a slot there.
Right.
Yeah.
And I think COVID really taught us, even though we had some temporary changes in how kids could get paid out in the program, but kids are
But I will,
sick.
and I will publicly say though, I really never supported going up to the 125.
Yeah.
Because we really needed to keep that monies for those that were less than 85, but that's my commentary.
Yeah, yeah. I think it's in recognition of even middle-class families, and these aren't even, I would say even lower middle-class families cannot afford childcare. So I think it's that hard, right? It is, right? It's that hard line of like, who else could be supported because it's really hard to afford. Yeah.
We think it's possible that 561, if it had been this year, might not have gone to the table.
Say that
But we
again.
aren't sure.
Could you say that again, Anna?
It's possible that if 561 were this year, it might not have gone to the table. We're not 100%, but that's.
Okay. Any other questions for Ms. Martin while she's up here? And how about thank you.
Thank you.
And how
Thank
about
you.
for
Thank you.
Anna or anyone else in the room? Okay. I would entertain a motion then. Representative Graham.
I make a motion ought to pass on LD 1728.
Ought to pass
As amended.
Okay, there's a motion. Do I have a second? Okay, Senator Brito. Any further discussion?
I'm not going to oppose this bill, but I feel very surely that if we catch the right people sleeping, this bill will slide through without any fiscal note. But I think the next administration might run into a headache. That's my delay. But like I said, I'm not going to oppose the bill, but I want Mike to say, I think in the future, this might cause a discomfort to the next administration. Thank you.
Thank you, Representative. Any further discussion? There's a motion ought to pass as amended and a second. All in favor?
And obviously that will come back for amendment review, by which time I'll have to ensure that there is no disciplinary.
Anna, can you?
Sorry. I'll obviously be bringing this back for amendment review after it's been through all of the loops. But we will have the fiscal note by then. And if it turns out there is one.
Okay. 2066.
All right, LD 2066. This is an act to establish the Child Care Employment Award. This bill establishes the Child Care Employment Award in order to provide childcare subsidies to recipients who are employed by licensed childcare facilities or family childcare providers and whose children are receiving care from such facilities or providers. It provides that subsidy awards must be provided directly. There's too many provides in there. Go directly to the childcare facility or the family care provider. It authorizes the Department of Health and Human Services to adopt routine technical rules around the subsidy award amounts, waiting list management, quality standards and limitations on the number of children supported. It requires the department to establish a full-time position to administer the award, and it provides ongoing funding of $3 million a year beginning in 2026-27. So you heard during the public hearing of the proponents, small margins for childcare. You also heard about the liability insurance and companies that are owning childcare. I believe there was one in Bar Harbor, but can't find staff and then closing them again. The program reached, this was a pilot program. It reached capacity quickly and a wait list was formed. Providers have both staff with the subsidy and on the wait list. And some of those providers are offering the benefit anyway at their own cost, but they said that they can't continue to absorb it. The pilot is set to expire and providers are worried that they will lose staff. And then the department are neither for nor against. There is an evaluation report, which you will have in a separate folder, I believe, that showed it had a positive impact on recruitment and retention. The pilot served 500 to 700 children from 300 to 375 families. 62% of those families in September 2025 also qualified for the CCAP. There were focus groups that they did. Nearly all who received the award had considered leaving the field, but the award allowed them to stay. And there was also a benefit of receiving care in the parent's place of work. The bill does require funding and staffing, or rather the program requires funding and staffing, and the committee would need to weigh the cost against the overall picture, including the CCAP waitlist. I did include the piece from the budget, Part TT from the supplemental budget that was signed in 2024. And I did, that was 2.5 million a year that was capped. And I did include sort of the highlights of the evaluation report, but I will not read that to you. OFPR preliminary fiscal impact statement, ongoing funding of $3,126,297 beginning fiscal year 26-27 to establish the award, as well as one social services program specialist position. And they said, based on a more recent information, the personal services cost for this position in 2026 would decrease by $3,979 from what it is in the appropriation section of the bill. So you would need to fix that, which is a small fix, if you want to move forward with the bill.
This is where we wanted to add. Yep. So this is where some of the language around prioritization. You want to articulate that again, or does Anna have that?
The prioritization is for the CCAP, correct? Okay. And I'll work with the department on how to word that, because I was flipping about trying to find a natural place to put that, and I'm not entirely sure where it goes. And the reason that matters is because if it's not there already, in order to add these in, we have to put all the other people in. So I'm just saying that that may require some wordsmithing, which is not an issue. I'm just letting you know that I don't see where it is. It could be that I'm just don't have enough time to look. But if you're wanting to add to the priority group for the CCAP, it may be that we have to put the whole thing into the CCAP law, and that's fine. But I think that's what I have to do.
Senator. Slide it. No, it shouldn't impact you.
Oh, there we go. Button issues again. So we heard of a bill this year that basically let the childcare provider not pass along the extra money that we're paying to the employee. Is that in this?
I don't recall.
No.
I don't think so.
Okay.
I mean, it's not.
I just want to make sure that if we're going to give out money, it goes to the intended.
So this is for childcare providers who have a child, who are on the CCAP, I think, and who have a child within their at the same, basically the childcare provider.
Okay,
So
thanks.
that money goes to the provider anyway. It doesn't go
Okay.
to the person. It's not like the salary supplement, which is what I think you're talking
Yeah,
about. And the
that's fine.
salary supplement goes to the person, not to the provider. But this is intended to go to the provider, but to pay for the child that
Pay
is
for the
of
childcare
person who
of
is
the
working.
childcare
Yeah.
worker.
Okay. Thank you.
The other aspect of this that we need to fix,
It's just a small change to the fiscal note.
which we'll make. Sure.
Get your steps in. I know, right?
Thank you.
Senator, did you have questions? for-
Yes.
So much, yeah.
You, can you provide clarity around the amendment that Senator, or that Representative McCabe is suggesting?
Yeah, I have some curiosity. So one thing I think with this bill, it's not a direct program within CCAP, but it does merge and blend and braid. So I think when we're thinking about the amendment, are you thinking just educators that are CCAP eligible? Or all educators for this program too?
It would be any childcare worker, teacher
Okay,
who isn't presently receiving CCAP would go to the top of the list in
Oh.
that priority.
Oh, I see. Okay, I'm sorry. So I have to repeat
Because
that back
otherwise,
again.
because if they're not receiving
GME.
this employment award, then they're
Right.
not getting anything.
and they're not getting
Oh,
anything.
I see.
So it would be CCA, they would have to still be eligible for the subsidy because they fall in
But
that
on the
income
wait list.
bracket.
Is that
But they would move to a prioritization of the wait list.
for this program, not
For-
for the CCAP.
No, for CCAP.
Yeah.
I'm
Because once
confused.
they're, yeah.
Okay, I'm just trying to figure out which way we're going. So
Well, I
that,
think it belongs in the other bill. I think it makes more sense.
It might actually now, yeah. I think what you have, so you have this program, because CCAP has federal rules, this program is kind of a side program that says, I fill out my application and check that I'm a teacher in a licensed childcare program, and then the application goes through the process of the income eligibility. If you are eligible for CCAP through the federal or even that 85 to 125% state portion we have, your paper goes over here, you get paid that tuition allotment.
Yep.
Then this program covers your copay
Okay.
to make sure, you're 100% covered. If I apply and I'm not income eligible, my paper goes right over here to this program
Mhm.
and I'm covered at a tuition portion to help me pay
Mhm.
and that retention strategy. So I think the intention, if we're talking about CCAP, those are the income eligible teachers that would be prioritized. There could be I don't know, this might be a department dilemma about where it would fit. Because you're talking about CCAP, but then a program that kind of blends and braids. Does that make sense? I think to me, the easiest thing would say your CCAP eligible licensed childcare teachers get moved into a priority population on CCAP. I think it could be done through this bill. It's just not within this program specifically. It would be another section. Does that make sense, Anna?
Yeah.
if I get this straight.
Do Tara or Bobby want to come up and help us untangle this?
Probably not.
No.
Yeah, they're both turned around now, yeah.
There's just 90% of
They're
teachers are
eligible.
not getting it.
Yes, yes.
So I think that they should be prioritized
Yeah,
for the CCAP population.
yeah. And so within that 90%, if the data says a little similar, about 64% are CCAP eligible, just not, still sitting on a wait list somewhere. You got 30-something% sitting on,
Mhm.
Theoretically, they won't be on that wait list anymore.
Yeah.
With this new influx of funds.
which would be nice, yeah.
But
Yeah.
contingency
But it could,
planning.
yeah. So if you're trying to fit it under the federal rules, they, I believe the department could have discretion to put a population as a priority
Consider it.
if they're working with licensed and within, as long as they're income
You
eligible.
think it goes to 1955?
Can ask that question.
Do you want to tag me out and?
Yeah, don't go anywhere.
Okay.
Um,
Do you, in your mind, both of you,
all of you.
and maybe all of you, is
Tara's gonna.
is it more easily done if this bill was folded into 1955 as we originally discussed?
Like a big package?
Okay, just a thought.
You don't have to introduce yourself again.
Yeah,
We know
I
who you
won't.
are. Bobby Johnson. Tara, you can introduce yourself.
Is it afternoon? Yes. Good afternoon. I'm Tara Williams, Associate Director of Early Care and Education.
Welcome. Thank you. So now there is a suggestion that perhaps this should be folded into 1955.
So just a couple thoughts is that this is
Yep.
a new
Yes.
amendment, and I think the department would need a little bit of time to figure out what the impact might be on the childcare affordability program if we were to prioritize.
Mhm.
I think as you're suggesting, childcare staff.
Yep.
In that priority one category to receive CCAP
Mhm.
and how that would impact the wait list, impact the funding within the available funds. And then for the Child Care Employment Award, those staff may continue to be on a wait list because the amount of available funding for all childcare staff in the state would require additional resources.
Well, understood. This is a new, something new added to sort of the landscape.
This bill is a new bill, so we don't have to, doesn't have to be worked by
Yeah.
tomorrow.
Thank you. Appreciate it. Understood. So I think at this point we need to table this bill.
That's fine. I'm just trying to figure out whether I have to hold up 1955.
Well,
I don't know anymore. I'm sort of confused.
go
Well,
ahead.
my thought was, since we're trying to create something out of the Child Care Employment Award as a separate program evolving from a pilot, that it makes more sense to me. We don't have to do it today, but it makes more sense to me to reconsider 1955 and add that piece that Representative McCabe was suggesting. And consider this bill by itself, but we can table.
Add one caveat to that. So
We also, yes, but we also want to give the department
Oh,
the
I
opportunity to consider and weigh in. So we could,
Yeah.
we could reconsider 1955
At a later date.
and table it
So that we can.
and leave this clean, or at least what we have in front of us,
Yeah.
and deal with it. And that gives us a vehicle, which, if I'm hearing this correctly, seems to be the right one or the most right one. It gives the department the ability to consider this new proposal and come back to us when we are ready to take 1955 off the table. Is this making sense? Okay, so, okay, thank you. So I guess then,
To explain that to President.
let's,
Do you like to come up? Do you have any thoughts?
No, I was just saying she
Why don't
gets
we-
to explain it to
Oh,
the President.
okay, let's deal with the bill we have in front of us. Okay,
okay.
right, so do we have any additional discussion on LD 2066? Did we have a motion?
No,
Not yet.
Okay.
motion, yeah.
It's getting very confusing in here tonight. So,
Maybe you want me to sit on maybe this is something we should think about and give the department an opportunity to come back to us with the amendment that we're talking about to see exactly what impact it would have how much that
On this?
on 2066.
Okay, because I thought
No.
what we were saying is that issue that
Right.
Representative McKay brought up appeared to be a better fit for 1955.
Okay.
And that we'd look at this bill.
I thought you were just kind of separating it. Okay.
Yeah.
I'm misunderstanding.
Yeah,
Okay.
to actually take a vote on this bill and move it off our agenda. And then we would have to reconsider 1955 and table it.
Gotcha.
So I would entertain a motion on LD 2066. Representative Zager,
Madam Chair, I move out to pass on LD 2066. This is as amended.
ought to pass as amended.
And
Is there a
that the-
second?
The change to the fiscal note, correct?
Yep.
I'll second.
Okay, there's a motion and a second. Ought to pass as amended. Any further discussion? Yes.
I'm really struggling with this because I really do support the Child Care Employment Award. I think it's really, really important. What I'm struggling with is that the department's wanting to add another full-time position and the cost of that position when we've got I feel like it's something that the department could absorb. So as it is right now, I cannot support this bill like that.
Understood. There's a motion and a second. Yep. Go ahead.
So at this date, is it necessary today that we tabled 1955 or can we is there a way to hold off on that
We have to reconsider.
until we hear back, reconsider? I mean.
We voted it, so we have to do.
We have to reconsider it today.
That's up to you.
Okay, I would say, anyway, that's a separate matter after we pass this bill, but I would suggest we wait until we hear from the department.
Wait for what? To vote this bill?
No, this bill, let's do this.
Okay, let's do this. Let's finish this.
Let's do this.
Please, we're having all kinds
Sorry.
of
Now
other
we sound like a
conversations going
Let's do
on
it.
here.
That
There's
was
a
more a
motion and a
process
second.
question.
Ought to pass as amended. All in favor? Those opposed? And the minority report is?
Do we want to go with mine? I would do an ought to pass as amended without the position,
Minus the position.
Okay.
minus the
Okay.
position. That's if I haven't caucused I guess that's okay.
Do you want to do corner caucus?
Do you want a corner caucus? Okay, all right, thank you.
So all of you, is that right?
Representative Daigle?
Are you okay with that, Representative Griffin?
Representative Griffin? Okay, okay.
Thank you. That's it.
Okay, so that's that. Now, what do we need to do with 1955?
Open for discussion. I would like to hold off on reconsidering at this point, if it's
Okay.
possible for a process, to actually hear back from what's the department's take on this.
Okay,
That's my suggestion.
Well, it does have an amendment, so,
there's work to be done on it.
yeah.
Yep, it's not,
Okay, so we can
it's
always
not
look
flying
at
out
it.
of here.
No, it's not.
So, okay,
Okay, that's my
all right,
motion.
okay.
If it needs to be a motion or if.
It doesn't need to be a motion. We've already done our work on it. There's
visit it
this
another
other
day.
conversation going on out here. The department's coming back with their thoughts and then we can deal with that once we review further information.
Sounds good.
So I'm putting a note in the file that says might need reconsideration on amendment.
Yes.
I write that because I have no memory and I'll forget.
Yep, we won't forget it though. Is there anything else on our agenda today?
Yeah.
Okay, so I would entertain a motion to adjourn.
To hold the bill.
Okay. That's true.
We're doing a number of them anyway.
Is this one of the carryovers?
And a second?
Yes.
All in favor?